So we are live, and I welcome to this you to the 17th IOACON Bounce Back webinar series. And we have today with us Dr. Ram Chadda, Organizing Secretary of IOACON 2020. We'll be missing Dr. Ajit Shinde, Chairman of IOACON 2020 today. So over to you, Ram sir.
Good afternoon, everybody. On behalf of IOACON 2020, I welcome you all for the 17th Bounce Back webinar. Dr. Ajit Shinde is occupied elsewhere, and I share his good wishes and welcome each one of you for this Demystifying the Tibial Plafond webinar. We have two of the most aggressive, well, I would earlier like to call them young because they're younger than I am, but now I would call them middle-aged young entrepreneurs in trauma surgery, Dr. Sushruth Babulkar and Dr. Sunil Kulkarni, people whom I've loved to always associate with over so many years, and they belong to the second generation of orthopedic surgeons, creating a third and fourth generation. And I'm sure that even the third and fourth generation, like the first generation, will keep discussing about demystifying tibial plafond as they are going to do today. So it's a pleasure to welcome each one of you. As you're all aware, things are probably moving in the right direction as far as COVID is concerned. We have probably not started flattening the curve. However, sooner or later, we should be able to get our livelihoods back as compared to our lives as well. As we stand today, I welcome you all, and I request each one of you to be as participant in this webinar as you would be in IOACON Mumbai, which, as most of you probably know, is moving towards the last quarter of 2021. Hence, we are looking forward to having the best of what you learn in these webinars with a face-to-face conference in Mumbai end of next year. Till then, we shall be connecting and looking forward to giving you as much information, knowledge, and wisdom so that you move from good to great to unstoppable in your orthopedic practice. Over to Sushruth. All the best.
Thank you, Ram. And thanks for giving us this opportunity to demystify the tibial plafond. Thanks, Ashok, as always, for the great technical support and the backup for this webinar. I must, at the outset, thank the terrific faculty which has gathered here, which includes Dr. Sunil Kulkarni from Miraz. Hi, Sunil. Dr. Girish. Has he joined? Girish Motwani from Nagpur. Hi,
yes,
Girish.
sir. Hello, sir.
Dr. Amit Asgakar from Mumbai, another great friend of mine. Hi, Amit. Dr. Rajesh Simon, who is from Kochi. Hi, Rajesh. Welcome. We have two guest faculty who have kindly consented to be waking up in the morning and being here. So welcome. Anish Kadakia from University of Michigan. Hi, Anish. Welcome. And we have Dr. Ashish Shah, who is at the moment in Florida, but is with us now from University of Alabama, Birmingham. And we have our own foot and ankle person whom I truly believe in, Dr. Sampath Dumre Patil. Hi, Sampath. Thank you very much. So with this, I'm laying down the rules. As we all know, this is case. Each faculty will present the case, and rest of the panelists will be taken along, slide by slide, question by question, whatever way you want to do it. Sunil, we start from you. Start sharing the screen and shoot. Sunil, over to you. Your voice is not heard. Unmute.
Can you see now?
Sunil, unmute. Yeah, yeah.
Yeah,
Okay.
yeah, we can see.
Okay. Now this is a 45-year-old lady, had a leg in a conveyor belt, and she had a massive open wound with a fracture dislocation of the ankle. And this is the wound she came day one. And if you can believe this, this is a real plafond coming out from the wound of the conveyor belt. And this is the articular surface of the tibia, okay, which is smashed. And this is a fracture, massively injured with the soft tissue around and dirt. And these are these x-rays. All right. We'll start from Anish. Anish, what do you think it is?
So this is a disaster, no question about it. I don't think anybody gonna argue that. The question is really, can you limb salvage this case or not, you know?
Yeah.
And in this case, I think it's limb salvage, not articular salvage. I would do, you know, IND, wash out, cement spacer, remove all those dead pieces of bone. Do not try to salvage and plan for a late TTC fusion with a bone block or acute shortening, depending on your preference.
All right. Ashish?
I agree with Anish. Like, it's more of like, you know, saving the leg versus the, you know, waiting for to amputate in the future, depending upon the consequences. Going through the external fixator, antibiotic spacer, having the flap coverage and stuff, and down the road doing the TTC.
What about Sampak? What do you say again? You want to say this, or you want to just do a secondary fusion in due course, planning to reconstruct or not to reconstruct? She's 45 years old,
Yeah.
working lady.
Yeah. Obviously, we like to salvage her joint as much as possible. And first, of course, soft tissue cover, and I will be a little late in fusion, TTC fusion, because our people, they tolerate arthritis for quite significant amount of time. So I'll be little joint sparing. At least my attitude will be for the joint preserving.
All right. What about Amit?
Yeah, I think, Sunil, this is definitely a very bad injury.
No doubt about it.
I know you all people there at Miraz have been salvaging these joints and doing one of the best treatments in India, you know, for all these open injuries. I am definitely sure that you must have taken it in. For me, I would also have given a very good wash or a very nice lavage, spent at the most around half an hour, 45 minutes in debridement, and then reduction of the putting this articular surface back inside, reduction of the fracture, maybe getting the fibula back in its position by either a nailing or so, and the primary K-wiring of the articular surface, and wait and watch, and if at all, add some antibiotic beads over there. Yeah, so that is what my primary protocol would be.
Can I ask the panelists something, Sunil?
Yeah.
Is there anyone here in this patient of rural India, young patient, would consider on day one amputation? Is there
No, not
anyone?
at all. We will not. Sushrut, at least in
Exactly.
India, I don't think we will.
That's what I wanted to bring out. That in India, rural patient where the immunity level is a little higher than maybe urban patient, the bugs are different than urban bugs. We may be at a higher predisposition of salvaging the limb, is what I'm coming to.
In
Will you agree?
spite of the heavy injury, surprisingly, neurovascular is absolutely normal. Otherwise, we would have amputated day one. But absolutely, there is no problem of neurovascular. So what will you do, Girish?
Yes, sir. I will go with the same thing. My priority here will be just to rule out the neurovascular injury, get the maximum alignment of the talus in the line with the tibia, so that we can plan for the good salvage fusion in the future. We will try to take out the maximum debris on day one, and will definitely wait with the external fixator in situ, maybe for 6-7 weeks with the antibiotic spacers.
All right. This is what we done at the day one after debridement, the temporary realignment of the articular cartilage, which turned out to be good. Only thing I would, after discussion, many things, we would have stabilized the fibula at day one in the alignment. We should have put a nail or something like that.
Yeah.
But we were not sure about that because the risk of infection, because it is come through the conveyor belt of in the rural areas, conveyor belts are very contaminated. The sugarcane conveyor belt.
Well, that's what I wanted to know. How much of contamination was there? And after putting your X-Fix, how much of soft tissue damage was still persisting? And probably how many re-debridements and re-look surgeries would you look at after your day one surgery?
No. The day one, we closed the skin. It's not much of a skin was not it was just screeched out, not the
intra-articular contamination.
And there was a lot of antibiotic contamination, but we debrided. We lots of debridement, jet lavage, and then fixator, and then we just put. If you see only the KY, just holding the tibial articular surface with that, which is very important to align that. Whether it will get into infection and then it will get into some sort of necrosis, then we would have fused it later. But when we get this as
unlike the proximal tibia or the shaft, the distal tibia, we look at this as more of a soft tissue injury rather than a bony injury.
Obviously, that's true.
Soft tissue and the contamination is something most worrying in tibial plafond.
Agreed. Yeah. Absolutely.
Sunil.
Yeah.
Did you keep the wound open or do you manage to close it? Because you've added
beads there, you see.
Beads are there, yeah.
Beads are there, and then we close it. There is no point in put a bead and keep the wound open. All the antibiotic will drain out.
No. Did you think of putting a vac?
No.
Okay.
No, we didn't put any vac. But the skin was so spurious, very thin. If you get the vac, that is excoriation of the skin is very common, especially in the distal tibia and patella and all these people. The locations are very precarious, already blood supply. So vac is the last thing which, if there is a lot of contamination, then we would have put vac. But usually the vac we are very restricted to only where the skin has got good thickness. There you can get a vac.
How was the articular surface? Was it?
The surface was good, only it was like a chop, like a chop. Yeah. So the cartilage was good of the tibia. The plafond was like a slice, like a cheese slice that's cut.
Okay, so it was one piece.
It was one piece on the medial. But there is a comminution on the posterior part. There was a comminution on the little bit posterior. But that I will show you what we have done afterwards. Once everything starts getting, anybody has any questions? Anish?
Why did you not fix the fibula?
That's what second look, because we are not sure of infection on the lateral side. If you want to open, everything is on the medial side was open. So we don't want to disturb on the lateral side. If at all you want to do some plating or something on the lateral side, we don't know. That's what I said. I would have nailed it initially, would have been good stability. But that the tibia was in very much mess on the medial side. So I don't want to open it.
Putting a rush rod. So put a rush rod.
That is a secondary now thinking, third process of now. But that time it was.
But probably, Sunil, I think even without fixing the fibula, you have done a very good job. It looks nice.
Yeah, okay. That may be.
Yeah.
Sampath, you want to speak something? You are trying to do something?
Yeah, in this fixation, I think most helpful thing is the transarticular Stillman pin which you have put, because it is across the talus and tibia. That has given you best
stability.
The open fractures, we depend more on this. A single Stillman pin across this transarticular pin helps a lot, and then this is a neutralization fixator.
This is to prevent subluxation of the talus, posterior subluxation, because posteriorly it was very much deficient. It was sinking down. So we just put one KY to hold on. We are just thinking to start that to prevent infection, because it's new stability. to good wound healing, and then we can fix anytime later stage. All right. Anybody?
You did this on the day of injury. This is your first operative intervention.
I think second or third day, not day one. Day one we just debrided, kept it, and then second day we took it. She came, I think, in the evening, 5-6 o'clock in the evening. But so we took her. Usually in India we don't do anesthesia and that, but we just give a proper debridement wash, and then we post, because they usually eat and then come. So all this anesthesia problem will come. But I think I remember distinctly that it's a second day afternoon.
You know, from the only standpoint, I think for the audience is that, you know, you did, it looks amazing. No one's going to argue with that. Here back home, we stopped fixing the fibula initially in most cases. We don't do anything.
Yeah.
For this terrible injury, I don't think most people here would not have put any metal in that for a week or two. That's the only thing it's amazing that, because that injury looked terrible, and you said it was a conveyor belt with sugarcane and infected.
Yeah.
I would have just put an X-Fix on and waited a week or two, wash out a couple times, and then just shoved it all back together and then consider it.
Dr. Kadakia.
This looks great.
I think it's just a KOS. It should be enough to get stability, because if you don't give stability of these article cartilage, especially when you get a very precarious blood supply as well as unstable fixation, will cause lots of infection. So that's a problem. If you get one infection there, then you can't save that.
Sunil, can I ask a question to Dr. Anish?
Yeah, why not?
Dr. Anish, what is your opinion and what is your protocol over there regarding the antibiotic beads?
Amit, put your video on.
Yeah.
So for the beads in this case, I don't think I would have used beads initially, but in many cases, we will put beads in any soft tissue defect after the first washout just to make sure it's clean. There's no real protocols anywhere in the country. It's just kind of everybody's particular kind of thought process. But I'm a big fan of beads and washouts and no metal. And everyone there's no science, right, behind this. Like for us, I would not put metal out, or no one in our institution would put metal in immediately for a case like this, because we're scared of the infection. Now, the argument to make it stable is the other logic to avoid infection. But the flip side is, if there is an infection, now you have a bunch of K-wires, transarticular K-wire from the subtalar joint into the tibia. Now you've got a bigger problem. So this is all philosophy. You guys are awesome at this stuff too. So, but that would be ours. Wash out initially, then beads.
Anyone else? Do we have any case, anyone showing to support what Anish is suggesting, Sunil? No one has such a similar case, no? Yes, no?
Yeah.
I have a similar case I'll be showing.
No, not now. But you're not showing it now, no, as a case?
I'll be showing one of the cases.
Similar.
Not a very similar case, but it's a similar case. Yeah.
Okay, Sunil, go ahead, please.
All right. So once all these wounds are healing, we removed the fixator initially, and initially we stepped down. We fixed the fibula to align this, which was showing good sign of healing. And
this is after how many days?
After
how many weeks or months?
Not months. Another 2-3 days or something like that. Because
Okay.
once the infection is not, we are convinced that there is no infection.
Sunil, any CT scans over here?
That time we are not doing any CTs because there was absolutely everything was on scene, my own naked eyes. So there is no need to take a CT. So now I would have taken a CT, obviously. But if you see, there is if you see here also, right from the beginning, there is a posterior big chunk. And there was a central piece was also missing in that. So we have to reaccommodate everything, whatever the possible, and salvage as much as possible. And then eventually we put a plate from the anterior, because the wound is okay. We don't want to disturb. Any comment on this, Sampath?
Yeah, it looks fine, sir. Because of soft tissue issues, you cannot go posteriorly. So that is why we cannot hold that posterior fragment. This looks good.
And I'm sure about that. I have already taken that she may need a fusion in future. because that was the main, because articular cartilage were normal, but there is some sort of missing pieces also in between. So definitely but you have to have a good stock to get a good fusion. So
the patient did not have any infection anytime during the course.
No infection, thanks to us, a good debridement.
Okay.
And we used to get a lot of that time, the era during 2012, 13, 14, they used to get a lot of jet lavage systems. We have a jet lavage systems to drain out and do a jet lavage. Nowadays, we are not doing it much.
Instead of this distal radius plate, could you today use something else?
Not at all. I'm going more smaller and thinner plates, because these are the low profile plates. If you use like a guy is asking distal radius, person is asking why you want to use a distal radius. So your lovely plate.
No, distal radius plate in a tibial plafond I'm talking about.
Yeah, it is. It is an excellent plate, which gives a very low profile, very high, very less, you can say footprint on the already precarious blood supply and periosteum.
Okay.
So I would still use a small distal end radius, even 2.7 millimeter if it comes. It makes no difference at all. If Sampath can tell me, he is also developing that distal tibial plate now with a very thin. What do you say, Sampath?
Yeah, agreed, sir. I mean, we should prefer these low profile plates. Agree with you.
Yeah, Ashish, what do you want to say something?
So question is, I mean, that as Anish mentioned, that we might do a little differently here, but this was a case in 2014, and now it's 2020.
Really?
And initially from the K-wire fixation to screw fixation versus this lower end radius plating fixation, would you have changed if this leg had survived, would you have changed your fixation here or type of fixation used here?
Majority wise, no, because I will still use a very low profile plate. Only thing, the quality of plate and the quality of reduction, because the adjoint of CT scan, so we'll come to know much more. I would have gone a little bit posteriorly in due course of time to get that good alignment. And I would fix the fibula first, not by this, but the locking plate on the lateral side, which is a MIPO type of technique, because it's a transverse plate. So these kind of changes I would definitely put in now, but definitely will fix as much as early as possible. And the debridement and rest of the things will remain same.
Sunil,
yeah.
Can I ask you a question?
Yeah, sure.
You have put that syndesmotic screw there.
Yes.
Yeah. So any for what was the reason, and has it served its purpose? And
yes,
tell us more about it.
Entire plafond is come out. So there was a syndesmotic injury. There is a syndesmotic injury completely. There are no ligaments were shown actually. It is complete tibial plafond. If you see first X-ray, the entire tibial plafond was out.
Yeah, correct.
It has to be both sides. It is so. It is that was the reason we will think of a fusion in future. In spite of fracture has healed, there may not be osteoarthritis, but due to syndesmotic, the both ATFL and PTFL is gone because of the injury itself. So we have to put a syndesmotic screw to stabilize and align the axis of the tibial. The crural angle has to be maintained. There has to be there is no any space increase in the medial tibial space is also maintained for lot less than 4 millimeters. So all these parameters.
One more question. Question is one syndesmotic screw or two, and through the plate or outside the plate would you have?
This is good enough. This is good enough because there was no space because there was all fracture. So I would have gone little bit higher, but the fixation was good.
Okay, good.
So these are finally after 9 months of surgery. We just removed we used to remove the syndesmotic screw because she was having some pain, and but it's okay. This is the movement. She is walking now. She comes. I can show you. I didn't get this year. She didn't come, but I call her come. She can show. She's walking around. There's no problem about it. All right. Anybody wants to ask anything, questions, anything, any something, suggestion? Anish?
No, I think you did a great job, man. I mean, I think, you know, there's some luck involved here because this lady had a high chance of infection and it looks good though. I think from my standpoint, I'm not sure her function would be that much worse off with the fusion. She's going to get arthritis. And so saving all that bone, I think, is a brilliant idea for a late fusion. You know, the fibula, I would have gone the opposite, more metal on the medial side and less metal on the fibula. I don't think the fibula needed so much incision. I think a rush rod or these fibular nails would have been a great idea.
I agree.
In 2020, you know, Ashish mentioned. And then the fixation medially is interesting. Less metal, I would have gone much bigger for the medial side.
All right.
100%.
Right.
If I was going to salvage it. But, you know, you cannot argue with what you got. Nobody can argue.
No. We are learning. We are learning from everybody, you know. It's not just what about
it looks good. I still in the end would have done, I would have ripped out a lot of bone and done a late delayed fusion. That's still my thought process.
Yeah. Shushruth, would you do differently?
Who, me?
Yeah.
Yeah, I might do differently. I might do differently. I might not put so much of a metal wear inside. Do you want to come off your, stop your slide share for a minute? Just for a minute, stop your slide share.
Okay.
Okay, and let me quickly, can you see this now? So I'm just going to run for a minute. This is the singular case. That's how it is coming out. Medial injury, and that's what I would do. Just fix fibula, nothing to be done on medial side, because I agree with Anish and Ashish, Americans. I was very skeptical about this on the medial side. Once the wound heals, I would go and put this kind of a plate percutaneously, and then eventually take the fixator out. That's 5 months down the line. So there are many ways to skin a cat, and I totally agree. In your scenario, you have done the best, but I would give more credit to debridement, Sunil.
Yep.
And you have done a fantastic job with the debridement, and that's how you could win over infection not happening. So that point needs to be praised. And I think second point needs to be praised is you pushed your jet lavage. Today we don't do jet lavage anymore because we know jet lavage will push the bacteria inside, So just normal saline, plain saline is the way to go today. But fantastic case, Sunil, as always. Shall we move on to the next one? Girish, you are ready?
Yes, sir.
Please share your screen. Let's move on.
Sure. So is my screen visible?
Yep.
Thank you.
Slideshow.
Yeah. Okay. So after the fantastic case by Dr. Sunil, now I am going to present a simple case, a fresh trauma, 15-year-old adolescent girl. She had some injury, fall from stairs 2 months back. And this was the soft tissue condition on day 1 when she presented. She was explained for the 2-stage protocol, external fixator, till we get a good soft tissue healing and followed by a definitive fixation, but she was not willing. So a slab was applied and patient went away. Patient returned after 2 months of the injury, and after 2 months, this was the X-ray picture. Some manipulative procedure was done by the local bone settler as per the history given by the parents. So how to proceed? 2 months down the line, soft tissues are completely healed, fracture still mobile with these X-ray. May I ask Dr. Anish sir first? Dr. Anish Khanna.
Yeah, this is asking me, my friend.
Yes, sir.
So in this case, I would plan if you said the soft tissue is healed now, right?
Yeah, I don't have a clinical picture, but soft tissue is completely healed. It was the day 1, and
she's 15.
Yeah. And
so I'd get a CT scan and see if there is anything you can salvage. She's 15, and if the distal articular pieces are 3 to 4 major pieces, I would argue you could still do a reconstruction, trying to salvage her alignment bone graft that massive that defect in the metatarsal area with either iliac crest autograft or, here I use a lot of allograft and bone marrow. And I would try to consider salvaging this because she is 15 if the articular surface isn't destroyed. So a CT would be important here. Even though it's a stretch, she's young, so you have to think about it a little bit more.
Yeah, it's a great point made by Dr. Anish sir that in a young adolescent patient, even though when the complete pylon is shattered and when the hope of the reconstructive potential of the fracture is not visible, even though one should try for the reconstruction rather than fusion. May I ask Dr. Ashish Shah, uh, what will be your opinion on how to proceed?
I agree with Anish and what you said, Girish. Um, Starting with the CT scan, soft tissue condition, um, being said there is no infection here, gaining the length of the fibula, uh, just like, maintaining the length of the tibia, as well as like, bone grafting, whatever the resources you have, packing with the uh, iliac crest, proximal tibia, if the fasces are fused, and if there are bigger pieces of the lower end of the tibia or the articular surface, you attempt or you give a chance with salvaging, possible remodeling, and by the end of the day, like with the same principle, you want to create a bone stock for the future surgery with as much as good alignment that you can get it here.
All right. So one thing is very clear that we want to see the CT scan. So from both the panelists, we got the opinion to get done the CT scan. This is the CT picture of this patient, and this is the axial cut. There's a lot of anterior comminution you can see here. Uh, this is a dorsiflexion injury by the talus, so there is a lot of anterolateral comminution. Posterior piece looks long and maintaining the good articular cartilage. Dr. Rajesh Simon, I want to ask how you will proceed from now. 2 months non or poorly uniting, delayed uniting fracture with such kind of deformities. Dr. Rajesh?
Yes. I will like Sampath had initially said. India, our patients do tolerate good amount of salvage, and a little bit of an arthritis always is there, and they don't complain. So, and plus the age factor. So, if you're looking at a fusion, which is very easy to think about, but long-term prospects of other joint complex problems. So, we always look like this thing. Now here, if you look at it, there's a gross combination. The valgus side is more injured. The lateral side, the anterolateral side, the failure has happened more in the lateral side than in the medial side. So I would probably think about an anterolateral and plus the fibula fixation. But definitely, I would definitely try to go intra-articular, start from below, put bone grafts, and from below upwards, I would build up, and maybe try do the fibula first to get the length, and then also do the anterolateral aspect of the tibia.
Yeah, so I think everyone is agreed that the fibula should be tried first to get the maximum possible ligamentotexis. But again, it is 2 months down the line, so we don't know the potential of the ligamentotexis. Dr. Shushruth Babulkar sir, what is your opinion? What would be your modality to fix a comminuted shattered fibula in a young girl in 2 months down the line?
So I would go right at the fracture side, break it open, pull it out to length. And I'm sure 2 months is not a big deal. 2 months is fairly easy. 6 months, then we are talking of difficulty. But 2 months, it's very easy to go trans fracture, pull it out to length. That's number one. Number two, as against Rajesh, what I would do is I would go right trans fracture on the tibia and push the article fragments from within out, push it down and push it up. So from middle, I will go down and above, and then it will also give me an access to maybe push that posterior fragment together. But here I would probably need anterior as well as posterior fixation both. So I would be ready to do anterolateral plating and also posterior malleolus fixation.
All
So
right. Dr. Sunil, sir, how would you like to fix this fibula? What will be your modality? Plate, uh, a nail, or both?
Nail.
So in a
Nail for
so,
what? No, I would use a two-column fixation. One is anteromedial, which is already anterolateral, because it is a lot of comminution with the same incision. I can put a fixation of the fibula. If fibula can come, you can just nail the fibula if you want, all you want to, and don't want to disturb mine. And I will use on the medial side also. Medial column is also very importantly, it is damaged. So medial column must be also reconstructed, and it is in slightly varus on the medial side. I mean so that you can have to correct that angulation, and then the articular surface is gone up, and you have to push it from and superior to down, so that you can create a void and you can put a bone graft there, and use a low profile plate. Now there's very low profile plates are available. You can fix it. Rather, posterior malleolus looks okay. If it is not okay, then you take a posterior medial incision and fix it. So approach is very important in this case. You have to structure the axial cuts properly and plan your central impaction, which is very important to realign. So how do you approach that central impaction? This central impaction is very important. So you have to bring that central impaction down at any cost, and put a raft like the screws there. You can put a simple screws as well, and rest of the you can build up with the plate.
All right. So in the axial city cut, we have a shattered tibia. So we have the anterolateral piece, posterolateral big chunk, and medial fragment, and posteromedial fragment as well, and with a small die punch fracture fragment. I would like to ask Dr. Sampat Dumre sir, what will be your approach to fix these fragments?
Actually,
Approach for tibia.
Yeah, actually, I don't mind little shortening of fibula here, because tibial metaphysis comminution, if it is shortening, I don't mind here. And it is difficult to distract fibula alone unless you address tibia. So I will take anterolateral approach and medial approach. Anterolateral approach gives the only exposure for the orthotomy purpose. I mean, we can see joint nicely through anterolateral approach. That is for orthotomy as well as for the anterolateral fragment. And medially, you can open the medial fracture site to disimpact the central piece. So I would rather mobilize tibial fragments first by anterolateral and distract it nicely to see the joint if you can get a better alignment. And then I will decide if at all I want to touch fibula, because here everything is shortening. I mean, comminuted tibia and comminuted fibula is a different this thing. If you get a good ankle plafond or tibial plafond, then we always say that we have to gain the length on fibula. That may not be required here.
Yeah, so you have created a very good point that anterolateral approach is a very good to see the joint. At least 70% of the joint you can see through the small anterolateral incision. But this was a healing scar. It was a transfer scar around the fibula. So posterolateral incision for the fibula and the posterior malleus, or if you not fix the posterior malleus, still posterolateral incision for the fibula, anterolateral incision for the distal tibia, and one medial incision for the medial comminution. So this was little difficult in this case. So I have started with the fibula work first, as Dr. Shushruth sir has mentioned. Getting the length after 2 months was little difficult because she was a young girl, so she might have a tendency to develop the bone early. It was literally too much of the work to get a fibular length. And also, I always use the recon plate, simple recon plate, but the locking modalities and the recon plate was not good in this case. So I decided to go with the, after reduction of the fracture of the fibula, I decided to go with the anatomical plate, and intramedullary K-wire with the loop with the plate were used to fix the shattered fibula. So rather than taking the anterolateral approach, I have taken the extended anteromedial approach here because the second incision was close to the scar. So this was the intraoperative picture. There were a lot of callus around, healing callus around the fracture. It was literally difficult to mobilize the fracture, and when I've tried to mobilize the fracture, it has created a big defect because of the mobilization of the die punch fracture, and it required the bone grafting in the subchondral region. So this is how it was plated medially and anterolaterally, and these are the intraoperative images. Talus was well centralized inside the tibia, inside the plafond, and the posterior malleus fixation was not done by the plate, and it was done indirectly from the anterior anterolateral plate. So this was the healing sutures margin, and this is the immediate post-operative X-ray. And this is fortunately got healed, and 2 months down the line, this was the follow-up X-ray, and all the fracture were nicely united. The length was well maintained. The articular congruence was reasonably good. 8 months down the line, weight-bearing X-ray, the talus was little tilted, but there was no obviously varus deformity. The ankle range of motion was good, and she was walking without any support. Dr. Amit sir, Amit Ajgaonkar sir, any your opinion about the fixation strategy?
Oh, very well done. It's really a tremendous job that you have done here. And 8 months post-op, such a beautiful X-ray, looking at the gravity of the injury in the first X-ray. Excellent fixation. I really don't have any to comment. But the only thing is that I wanted to just ask, just an opinion. Sampath, you just told fibula shortening in these cases, but in tibial plafond fractures, can you just give us more clarity about fibula shortening? Can we really, because that will affect the ankle mortise if you shorten the fibula.
Yeah, I mean, in this difficult situation, I won't say by choice, but in this situation, even there was shortening on tibial side as well. I mean, just to avoid bone grafting that area, because the ankle plafond, if you are putting it neutral, I think even we can accept that. I would have first tried, I would have tried on tibial side. If I am able to do it, then I will mobilize and go on fibula.
Because generally, whenever you distract or if you plate the fibula, you gain the length, then because of the metaphyseal crushing of bone, you create a void over there, and that needs to be grafted many a times. Once that void is created and your impaction is really ankle congruity is achieved, disimpacted fragments. Anyway, it's a very excellent fixation.
Dr. Sunil, you want to ask?
Yeah, the shortening, Amit, he wants to see the dime sign. You have to see the dime sign.
Yeah, exactly.
The fibula is gone down or up. That is a shortening. Supramalleolar shortening is acceptable, very well acceptable. There's no doubt about it. The infra syndesmotic shortening is not active. If the fibula shifts up, then you get lots of problem on mortise. Third thing is when you want to put you already decided to put an anterolateral plate. So you could have taken Helfet's incision, would have taken one only on the lateral side, anterolateral approach. You could have fixed that on the medial, taking a medial side and coming back to anterolateral and also there is a widening of the, if you see the lateral X-ray, there is a lot of widening of the fragment of the plafond. I mean, I don't know the CT scan, but if there is a widening of the posterior malleolus, because already your syndesmotic is injured, and the posterior malleolus fixation would have given a much stability by a small plate on the medial side. That's what I would have done.
Sunil, but these fractures, generally the tibial plafond, are more of the anterior injuries. So, anterior opening and opening the fracture like a book and seeing the congruity of the articular surface, disimpacting. More or less, your fixation is more anterior and medial, and
I
the fibula
understand.
fixation. Yeah.
But this is a posterior malleolus in the medial side, right? This is not the posterolateral fragment.
Correct.
No, but I think you have held the
Posterolateral
posterior
fragment.
fragment with the anterior screws, probably.
Yeah, so posterolateral fragment is more involved with the syndesmosis. Posteromedial fragment, like what Girish has done an excellent job. Only one thing which I would like to ask a clarification: in the medial side, you used a recon plate. Would you have probably done a MIPO with an anatomical plate if given a choice between a recon and an anatomical, because it is easy to slide in a medial plate, though it stands out a little more, but otherwise very good fixation.
Yeah, it's a good question, sir. Actually, I have taken the anteromedial approach. It's an extended anteromedial approach, and through this approach, I can easily slide a recon plate. Again, why I have not used the anatomical medial plate is because she was a young adolescent girl, and none of the Indian implants they have a perfect contour for the adolescent distal tibia. Even in the this anterolateral plate, you can see it, this is little away. If you see the proximal end of the plate, it is little away from the bone. So this was a problem with the Indian implants, or any standard implants, but for the adolescent pilon they are not made. So that's why I have not used the medial plate. I have tried it, but I have not used. And again, this was thick. It was 3.5. And this is a 2.7 recon, so it was little easy from the same approach, and it was little anatomical.
It is otherwise very good fixation. Secondly, you said about the fibula. Now in fibula, you have used more of an anatomical plate rather than the normally, which we normally advocate as the non-anatomical plate.
Yes.
So, I mean, looking back, do you really think it was necessary to put a anatomical locking plate in fibula? Because that again, it's a big plate.
Yeah, so I tried the simple recon plate, 1/3 tubular recon plate first, but I was not getting the distal holes. I was not getting the distal purchase. So that's why I took out that plate. I did the intramedullary K-wire was there, the temporary fixation was there, and on top of that, I tried to put anatomical plate so that I can get more distal hole purchase.
So once you put that plate, why didn't you remove that intramedullary nail? Because
no, the intramedullary wire was there from the beginning. This was to achieve the length after the aggressive mobilization of
because it's a solid fixation once you put a locking.
Yeah,
plate.
but this was unstable. She was 2 months non-weight bearing, immobilized. She was neglected pilon. The fracture mobilization has created a defect. So it was literally a kind of very unstable 3 to 4 pieces of the fibula.
Girish,
Yes.
there's some angulation, posterior angulation of the fibula. You can see over there. And your fibula plate in the lateral view is tilted, maybe because of that. Did you have any problems in fixation of the fibula there?
Yeah, so this is not perfectly on the lateral surface. This is the best possible bony surface where I could have achieved the fixation of the plate.
Girish, if you see the CT scan of the medial malleolus, there are hardly any screw. See the CT scan. See the CT scan of the medial malleolus. Yes, see this. The big chunk of the medial malleolus has got only one screw of your recon plate.
Plate should have come slightly distally.
Yes.
Distally.
Correct.
Yes.
You're the only one. That's what I think Rajesh was asking, whether to bring that plate, the anatomical contour plate, so that you can have a good fixation on the medial malleolus.
Got more screws in the medial malleolus. Yeah.
Yes.
Yeah. So at least 1 or 2 screws. So only hardly one screw is holding. Lucky you have got union, but usually the medial malleolus go into non-union. So it is wise to use a simple malleolus screws along with the plate. Would have been one screw, a malleolus screw going from tip of the medial malleolus to stabilize that, and with a good enough. Yeah.
May I have one last question to all panelists? Is this talar tilt is acceptable in a weight-bearing X-ray, or I should have done anything differently so that this tilt of the talus
Is this
can
a
be avoided?
weight-bearing X-ray?
Yeah, this is a weight-bearing X-ray. Dr. Anish sir, do you do any soft tissue reconstruction, or do you feel a need of any other procedure to avoid the talar tilt?
So, in this case, I think you have to be realistic. We can all argue the little details of how you fix it and this and that, but this ankle is gone. It's going to get arthritis. The main goal is not to get infection, not to lose the leg. You did a big incision, which I think was okay. You did do a lot of dissection of the periosteum, which if you look at your intraoperative picture, which was awesome, but you stripped all the periosteum. I would argue if I was doing this, I would have only stripped the periosteum distally and left all that periosteum proximally and maybe done a lesser soft tissue dissection, because this is a case where if you get unlucky, the leg will come off. The whole thing gets infected. So I think the thought is, all the arguments about talar tilt and irrelevant. This lady's ankle is gone. Accept that before you start the case. Your job and what you did was to realign the leg length, rotation, angulation, alignment. That's it. Go home, which you achieved. The talus tilting is because you got a defect on the medial articular surface. It's not because there's some soft tissue issue. It's because the posterolateral or posteromedial tibia is still proximally subluxated because you didn't do a posteromedial osteotomy. I'm not saying I would have, but that is the anatomical reason why. And the medial malleus is probably slightly short because of what everybody has said. You didn't have perfect fixation there. And that's why her talus is tilting. So you have articular defect, you've got some slight bony malalignment posteromedially and medially, so her talus is going to tilt into that. But overall, she's got a reasonably aligned leg. We can all argue that we each would have done something differently and maybe slightly better. But the truth is, this is the goal that we're looking for. But no soft tissue, that's not your problem. This is a bony loss posteromedially. That's why her talus is tilted.
All right, thank you. Thank you, everyone. Over to Shushruth, sir. Yes.
Thank you. Excellent case. So let's move on. Girish, can you stop sharing, please?
Yes, sir.
And Amit, you are ready with your case?
Yeah. Can you see this?
Yeah. Go ahead.
A road accident, 31st December, a year-ending party. I think around 3-4 years back. And this whole thing, I was carrying the articular surface and it was out. X-ray. The whole Shaput's fracture with the articular surface was free on table, basically free of all soft tissue. So, Dr. Anish, Dr. Kadakia, comments on this. I've got a CT scan also, but can you just start commenting on this?
So, the principle is, on theory, you have an open fracture with a free articular piece with no soft tissue coverage. That is dead. In theory, that should be thrown in the garbage can. That is the principle, right? If you look at the book,
yeah,
gone. I had a broke my ulna free piece. He threw it in the garbage for me. So I know you guys will wash it and shove that sucker back in for sure, right? But, all right. But I think for the audience, you should know the principle is you throw it out. And I think, again, if I saw something like this, open piece here in America, we'd probably obligate it to throw it out or record that had some soft tissue on it and lie. But same thing, X-Fix for us, X-Fix, I would put vancomycin powder inside now because it's very cheap. No fixation, wash it out like you guys I'm sure did, and then go back and try to reconstruct it. But if you're going to reconstruct it, you have to put that piece back against the standard principles.
Would you plate the fibula?
No, it's funny. So and Ashish can comment too, but in the States, initially the idea was to X-Fix, plate the fibula immediately. But now most of us feel that we X-Fix, get alignment, get the CT, and then plan everything at once, because sometimes when you do fibula fixation at the same time, you may compromise your overall planning. It's like, I should have gone more posterior, should have gone more anterior. So a lot of us will just leave it and then fix the fibula in a week or two.
Okay.
Yeah,
Ashish?
I agree. Like, that, and one thing, like, one mistake number of people do, they do CT scan. The moment the patient is in, you do CT scan.
Yeah.
I know you do CT scan to rule out the other injuries at the same time, but you put the external fixator there and then you go for CT scan. Don't go for CT scan to begin with here, unless there is other polytrauma. But this is, again, one more thing on top of it's pelons are not just a bony injury, it's a soft tissue injury as well, right? So
This
putting
is the articular surface, which is the Shaput's fracture. It's a very big articular surface.
if you look at the literature, Anish mentioned, like, there are just a case series of few cases. I mean, there were few studies, like, one was the combination of 3 cases, one was the 2 cases, but every time this turns disaster. Basically, anytime this is out, it's out. I know that people wash it out and put it in, but there are higher chances of, right now, if I take this articular surface out, there are higher chances I can save the leg versus I put the fragment inside and with getting the full-blown infection down the road. So if I'm here, like X-fix, then CT scan, this fragment out, wash it out, when there is a reasonable healing or no infection, I mean, reconstruction, like, the 2 weeks, 3 weeks, going for the fixation here.
Okay. Thank you, Ashish. Rajesh, a quick opinion. Would you keep the fragment, the loose fragment there, or wash it and keep it back, or throw it away?
What's the age of the patient?
Around 34, 35.
Yeah.
A very active young male.
Yeah. So the whole idea of the thought process between the Americans and Indians are probably in a different context. We try to salvage as much as possible, and they try to
throw away as much as possible.
Maybe our
and that's American principle. Throw away.
Yes.
So we probably try to salvage as much as possible, but then this is a very bad injury. Looking at the X-rays, the soft tissue also would be very bad. And in pylon, I'm always worried about the soft tissue first before I look at the X-rays. So yes, so it is not the X-rays that alone dictates the term of planning. It is also the soft tissue.
Yeah.
So the soft tissue.
Rajesh, are you going to keep the bone or leave the bone? He asked you a question.
So that's the soft tissue depends upon the soft tissue. If there is no contamination, I'll keep it. If there's
Rajesh, there is always, it's an open injury, it's a road accident, there is contamination.
No, it depends upon how much of contamination.
No, it depends upon your debridement. Debridement, you lose all the contamination. But then will you keep that loose piece of bone over there, which is lying on the road and got to you by the patient?
We have done it before, so I won't say I want to throw it.
Great. So you are an Indian, so you'll keep the bone back there. Yeah. And Sunil, Sushrut, I think you surely will keep the bone. Sunil?
Obviously, we'll keep it. Always keep it.
Yeah.
Unless it is really loaded with mud and something like that. But usually, so we have to see. I actually published along with the Ganga Hospital, we have a reinsertion of the fragments, which we autoclave and put it there to prevent infection, but not the articular cartilage. But we can put it and try to send. Yeah. Of course, you take confidence of the patient that he might lose due to infection, as well as losing the ankle as well.
So the only difference, Amit, is I would do immediate X-fix medially far away from the focal site so that it will not interfere with my future implants. Immediately bring in, and maybe day 2 or day 3 fix that fibula. Not wait for a week or 2 weeks, but day 2 or day 3 fibula, and maybe 2 or 3 weeks for the definitive fixation once the wound is better. That's the only difference.
Okay.
Approach. The spanning, scanning, and planning is definitely here is very important here. the span, and then do a CT scan, and then probably, as Dr.
Yeah.
Shushu
So I
said,
think all world over we have agreed on that X-fix, traction and density. We have agreed on that.
But
Right.
Mumbai, they don't do it. Mumbai, they only do first immediately CT scan, then external picture or splint only. That's a Mumbai.
CT scan, yeah, CT scan, Mumbaikars, yeah. So,
I think the rest of the world, apart from Mumbai, is
no, not that. We are just joking.
sure.
Anyway, Girish, a quick opinion. Girish and Sampath. First, Girish, yeah.
Yes, sir. So if the fragment is loose, having no soft tissue attachment and contaminated, definitely we will throw it. If it is attached with the soft tissues, if it is uncontaminated or less contaminated, we will try to save the fragment.
Girish,
with the maximum
one question. Very less contaminated, but good debridement done. That was I had done that, and but it was carrying a large, around one-fourth to one-third of the articular surface and the sharp hoods, that the anterior ligament of the syndesmosis.
So considering this situation, yes, keeping that fragment is a good decision.
Okay, Sampath.
Yeah.
After 10 years, Girish, you will start saving that each small tiny piece of Indian bone. I'm telling you.
Yes, actually. Anyway, Sampath, your opinion?
Yeah, I agree. I will conserve it. I won't throw it.
You will conserve that fragment. You will keep it. Yeah. Okay. I did. This was what was the X-ray, a proper X-ray. You can see this large piece. It is carrying over here the whole of the articular surface and this is the fracture. What I did was I went ahead and did this. This was for day 1 surgery. You can see the date. It's 2nd of Jan. So he had come to me on the 1st of Jan, I think, in the evening or so. So comments on this, Anish?
It's interesting. Your philosophy is very different than how we think. I don't speak for Ashish, but it sounds like in India, you guys think you can save the ankle more than we can. Maybe we're more despondent, but you see pilon, that thing is going to, like, that is not just a pilon. That's a pilon. That's a real massive injury. That ankle joint is a lost cause. 0% chance. I mean, only do foot and ankle. These people all get arthritis. And so in our mind, our goal is to never get infection, because you get infection, that leads to a whole road of pain. And so I would throw that piece out in a heartbeat, put beads, no fixation for at least a couple of weeks to make sure it's clean, and then fix the fibula, everything at the same time once I know my plan. Fixing it immediately is okay. The fibula looks fine. There's a little defect there. But I just don't understand the benefit of the initial fixation in the setting of a contaminated wound. What is the reason that this is? I have to admit ignorance in the Indian trauma concept, that you put fixation so quickly when it's open, and not just a grade 1. I mean, these are bad open injuries, and that's a dead piece of bone. So that's what only thing I said for us, it just doesn't compute for us. Clearly we don't have as much experience as you guys. So I'm curious, it's the opposite of what we would do.
Yeah.
Can I take this, Amit?
Yeah.
So Anish, we have evolved from not doing fixation like you to debridement, and we believe in that debridement, number 1. Number 2 is, if we lose that day 2, day 3 temporary fixation as Amit has done, if we don't do that, and if we ask our patient to go to the village and come back in 2 weeks, he would not come back in 2 weeks. He would come back after a month. So we would lose there. And if we lose there, if he comes back after 6 weeks or 8 weeks, then to bring that fibula out to length becomes so difficult. So we have, you locate the wound, you choose a plane which will not hamper or accentuate the infection. So go posteriorly, flat surface of fibula, go laterally, put it anatomical plate, stay away from wound, but try to fix fibula out to length is the principle.
Okay, so that makes a lot of sense, because there's a timing issue which I didn't understand. That makes a lot of sense, because you can't lose that window for sure. That's a problem.
And the last thing is, our patients are so tolerant to minimal ankle arthritis as against workman's comp that they would continue with that little bit of pain and accept it to a great extent.
And Anish, can I add this?
Of course, but
Yes,
Yes.
Yeah. So now if you throw this piece off, it's a big chunk, there will
Yeah.
be a huge defect. And afterwards, the reconstruction with the defect or a bone transport will be a hell lot of a big job.
Yeah.
So it is better to retain it, see for 2-3 days, is there any chance of infection? You take a good compliance of the patient. If there is no infection, continue as temporary fixation Amit has done.
Yeah.
And if you are lucky, you go and start continuing the situation. But this is the area which we have to be very balanced about keeping and non-keeping that fragment.
Yeah.
So what we
The
try to
other thing
save
is,
it
Sunil,
as much as possible.
Sunil, the demands of Indian patients are different. They demand quick surgery and quick healing. But of course, that's not possible if an infection catches up. But at least a surgery on day 1 or 2 would at least satisfy them. Then they carry on with the infections. They carry on with arthritis. They come to you for dressings. And then,
That's not the physiology.
I do understand that. But then you tend to lose your patients also. Anyway, I'll just, any other opinions? Rajesh?
It looks good.
Okay. And Sampath?
Yeah, I agree most of the points. Only issue is, if at all we are committing for initial fibula fixation, I won't choose lateral approach. I would choose posterolateral, because lateral approach blocks your anterolateral, posterolateral approaches. So if at all you are committing, don't get committed day one, as Dr. Anish said. So you have to be very particular about the future incisions. So
Correct.
if at all you have to take one incision, please take posterolateral. If at all.
Right. And probably the fibula is rotated over here.
If it is non-comminuted, Amit, then you might as well put a
Nail.
rough nail
Exactly. Yeah. Retrospective thinking, I thought a nail would have been better. It would have sufficed.
non-comminuted, yeah.
Girish?
Yes, sir. So I could totally agree with Sampath, sir, that anyhow, like in any situation of the pilon, my thought is not to put a direct lateral fibular incision, because if you take either anterolateral or posterolateral, that will be very close to that previous incision.
Yeah, Sampath, you're absolutely right, because that fibula plate gave the problem till the end. I'm telling you now, you know what is going to come in. It's really a funny case. I'll tell you what has happened. Now, this was after around 15 days of fixation. Comments over here. Now, here the patient, there was infection. Patient got infected. We thought of removing the fixator or the... Yes, I want to ask you, it has got infected. So what to do now?
There is infection.
The infection is anterolateral over here in this portion, in the portion of the lower end of the fibula and the anterolateral part, basically.
Okay.
From where this thing has come out, the shaputs had come out.
All right. So you have to put beads, start using beads. Why don't you use beads? Why you are not using beads?
Yeah.
What's wrong?
You're right. Absolutely right, Sunil. Yeah. Anish?
You know, that's what we fear the most, but now you bought it. So now you go back in, hardware comes out. But if you have experience with a ring fixator, that is your next best choice. Okay. Because now you have infection. I would argue the hardware has to come out. I would take that anterolateral tibial piece out that you knew was devascularized and out. Antibiotic cement spacer or beads. Get it to heal with a ring fixator, keep it out to length, and plan for an ultimate ankle fusion with some sort of bone graft. You could theoretically say you want to salvage it, but take everything out and then use a ring fixator with aggressive use of beads multiple times to get to clean and see if you can salvage it. But I don't think any internal fixation is going to be left in this case. I can't argue that you could try to leave this in there.
Okay. So everyone agrees to it that all the implants have to come out?
Yes.
Any opinions? Ashish?
I agree. See, any part of the world that we practice, one principle for this type of injury is to prevent the infection and creating a good bone stock for the future surgery, right? So here, like, you know, that we need everything to come out. Lately, in the last couple of years, with the peel-on, dusted peel-on, with the open peel-on, with the patient with the diabetic smoker, like my partner has started doing more of the after external fixator after 1 or 2 weeks, instead of like opening the peel-on, he will put the rod from the bottom without prepping the tibia, ankle joint, or subtalar joint. I don't take those many trauma calls. I do like a couple of times a year, not more than that. But that's one thing to consider, like, that you put the antibiotic rod or something, the all soft tissue will heal. You are not worried about the bone infection for the future, and then you can do the surgery, like, fusion in the future. So here I agree, we have to take everything out with the ring fixator.
Would you take that loose bone piece also out? Because once that screws come out, it will be all out.
Yes, and the thing is, we have to understand this is a high energy trauma.
Yes.
Just putting the 2 or 3 screws or multiple KRs, you need to be just lucky to save or to maintain the length. I mean, you need the definitive fixation down the road. So my point is, yes, this begin with, like, with the smaller, that avascular piece, it needed to be come out for sure.
Okay. Rajesh?
Yeah, sorry. Yeah.
Now that it is infected anterolaterally, so do you think all implants have to come out? It was not like pouring pus, a little bit of infection, like a little bit of pus coming out, but anyway, it was infected.
The worrisome part for me is the lysis part around the screw. If you look at very carefully,
that probably no, Rajesh, that's the digital, sorry, the X-rays which show lysis. Even in
if there is no lysis,
there's no lysis.
If it is not there, then I would probably again try to salvage more before I go into implant removal. I'll try to do all the proper debridement, antibiotics, antibiotic beads. And then if it still is not pouring, it's still pouring, then yes, removal of implants. But I'll still give a try to salvage before I go for the dismantling.
Right. Sunil? Okay, Girish?
I think we should now debride it, take off all the implants, and stabilize. If at all you are worried about, as Anish said, we can put a ring fixator. Usually, peel-on, we don't interfere with any internal fixator at the day one, probably. That is a mistake. Or the soft tissue around are not allowing you to give. But you need to use Elizaro fixator. That is a much better now for these kind of salvage procedures.
Okay. Girish?
Yes, sir. So this is very important to understand the role of the fixator in the first stage of the peel-on management. In my experience, in my limited experience, whenever I have tried this two-stage protocol, I never got a good reduction of the peel-on fracture with the external fixator only. And the purpose of the fixation is external fixator is just to assist you during the definitive fixation and not to give a good articular congruence on the external fixator support only. So this is always better not to put any intra-articular to fix any intra-articular fragments or the internal fixation in stage 1. And this has happened in our situations. So now take out all the implants, particularly all around the anterolateral aspect where it is infected, and wound was also there. And we need a thorough debridement, and we need to keep the same external fixator considering the use of the future assistance.
Okay. Sampath?
Agreed, sir. Now, I will try to debride and remove the implants, whatever they are.
Sampath, could you remove all the implants?
Not all, but we end up in.
What will you keep then?
Screws I will like to keep because limited fixation for articular part,
But that particular loose piece, which probably was infected as a cause of the infection, is there. The screws are holding that. So would you keep that loose piece, which is there with the screws?
Yeah, I will try to keep it. I will try to keep it as if now. But day one, I won't be aggressive with the soft tissues until they show me their behavior first.
Okay, I'll go ahead. Stimulant. I removed the fixator only and added this stimulant, which is a calcium sulfate antibiotic beads. So this was done. Opinions, Anish? And
That
now
is the opposite of what I would have done, 100%. So I'm assuming you're going to save the leg and not end up in an amputation, but I would have left the X-Fix on and taken out the metal instead. I mean, stimulant I know we use here too. You have to have a lot of faith that you're going to be able to kill that bacteria in that avascular bone with your foreign body. And I guess maybe our philosophy here is that two things. One, I think pelons go to arthritis symptomatically much more here, and we're more limb salvage in the fact that an infection for us and we lose the leg is devastating for the patient that can't handle it. Medical legally, we can't tolerate it. So we may be a little bit more gun shy, because if you presented this as a medical malpractice case in America, and Ashish can correct me if I'm wrong, you lose. This is not this is in our country. Everywhere is different. So part of that is we are a little gun shy about this. If you get lucky, I'll give my hats off to you. And the other argument I would have is, do you really think that articular surface is reduced? You keep those screws in, but are you keeping the screws in just to keep the bone? Because that articular surface is really not reduced.
That was a huge defect. So I was really tempted to keep it back there.
But why did you remove the fixator, Amit? You made it more unstable.
I had to put a vac also. On this, I put a vac. With the fixator, putting a vac was very difficult.
No, but you could have changed the fixator, the pins or rods can be changed.
Yeah.
But you cannot compromise the stability of the fixation.
But this was after around 3 weeks. So now this is the 5th week of...
Then, if it is infection, you are making unstable.
Okay.
I'm with Sunil on this one. I think more, you could have made a medial X-Fix. I mean,
yeah, correct.
To stabilize and keep waiting for that metadiaphysis. But I agree though, putting vac in an X-Fix is a pain in the rear end. Nobody likes it. It sucks.
Yeah. And yes, Ashish, your opinion?
Yeah,
would you also remove the X-Fix or keep it?
I would prefer keeping X-Fix, and given scenario with the infection, I wouldn't have mind to change to the ring fixator.
Yeah.
So basically now I know that, there is nothing much I can offer to preserve the bone stock. The only negativity I see, this stimulants, it looks pretty on the x-rays. It does some work, but I've seen in my practice as more drainage from the wound.
Yeah,
it happens. Draining a lot. So, that it's give and take, okay, what am I gaining, risk versus benefits, so just be careful with that.
Yeah. Rajesh?
Yeah, I agree. The stimulants are good, but it creates a lot of drainage. So at times you're confused whether it is good drainage or pus or something like that.
Basically,
but I would definitely not remove the external fixator. Probably I'll readjust the external fixator. Or if if there is a ring guy, I would definitely go for a ring, but I would probably not keep this because a unstable fracture leads to infection. Unstable things are not good for infection. We all know that. So it creates a macro motion, and macro motion is not good for fracture. So it leads to infection. So probably we need some kind of stability, and this plaster slabs or whatever, even for a vac, I think it's dangerous.
Right. Sushrut?
I think, I'm listening. I was waiting for you to ask me to speak.
Yeah.
I think one thing is very clear about articular surface minimal fixations is if we think that we have reconstructed articular surface to whatever extent, and if the implant's purchase is good, no need to remove them. Number one. Number two is, I don't think that anterolateral fragment caused the infection. I think inadequacy of debridement caused the infection.
Yeah.
The virulence of bacteria caused the infection. The internal fixation never caused the infection. It will allow it to retain once it is there by forming the glycocalyx or whatever.
Okay.
I think now it is okay. If you are convinced on site that the purchase of the implants, the purchase of the screws is good, it is okay. I would probably would have done putting gentamicin beads day one, but now I would not have removed the X-fix, because
Right.
more instability you create, the infection will stay longer. It will not.
Yeah.
So instead of going away in 3 days, it will go away in 7 days. You know, so more instability, more it will stay for a longer time. But I think let's go on. Let's see what you have done.
With the stimulant, actually the infection came into control. And
whatever, quick word about what Rajesh Simon suggested. Stimulant doesn't cause oozing. The Indian counterpart, Surgiwear, it causes oozing for a long time. But
no.
stimulant,
So it is the calcium sulfate which breaks down and that comes out. It is not an ooze. It is the powder of the stimulant
Powder
which
that comes out.
Yeah, it is that.
It confuses you over a period of time.
It is not a ooze. It is the powder. Yeah, it confuses. You feel it is a ooze, but it's the stimulant, the calcium sulfate powder. So this is at 2 months, Girish.
Yes, sir. So I agree with the with all panelists that we should continue the external fixator in situ, or you can change to the frame.
But now it is 2 months, huh?
Yes. So at this moment of time, I think CT scan will give you a little
Now,
better.
For what? CT scan for what?
So are we sure about the control of the infection?
No. It is not fully controlled. No. I'm telling you. I ask you CT scan for what?
So CT scan will tell us about any radiolucency around or ongoing infection, continuation of the infection, chances of the non-union, the formation of the new bone around the fracture, and maybe the definitive the approach for the definitive fixation.
Okay.
Girish, you're being nice. This is osteo. I don't mean to speak up too in model place, but 2 months out, no healing, lucency along every single fibular screw distally. You can see on the lateral, there's some and lucency around the tibial screws. You have to presume this is osteomyelitis.
Yeah.
100%. No matter what anything's happened in India, this is osteo. I don't mean to be, that's what this is. Let's be clear.
The digital x-rays, they show this type of lucency around the screws. That is what we feel in India. Most of the times, even post-op x-rays show this lucency around the screws. Anyway, for take my word, there was the infection had reduced. And Sampath, what do you feel now?
Infection is reducing and soft tissues are okay. I will wait for ultimate soft tissue healing. One thing is sure, that only soft tissues and infection will decide how do we go further.
Okay, I'll go ahead. This is at 3 months. This was the wound, only wound. Now in this case, this is at 4 months X-ray with that wound. What next? Anish?
I will repeat what I said last time. This osteo. Now you're looking at the plate, you're looking at the tibia. This has to be cleaned, all the hardware removed, put an X-fix back on, either you can try to vacuum once you get it all clean and then come back for a late TTC fusion, or you can do a flap if you have someone who can do a flap for you. I would prefer a flap to get some healthy coverage so I can get that to heal.
So now look, we have removed the external fixator at around 3 to 4 weeks, put stimulant, and this is the picture at 3 to 4 months. And Ashish, your opinion?
Yep. all hardware needs to come out.
Yeah.
For doing the soft tissue procedure, you need to put the X-fix on or ring fixator on to do the flap surgery. Uh, Now, like, earlier, that try to get the function, then now we are more of at the point to save the leg, right? So, yeah, to
Yes.
save the leg, you need to take everything out.
Yeah. Rajesh?
uh, would think completely in a different way. Only my worry is how is the ankle joint? How is the general blood parameters, everything, general debility and the ankle movements?
General, everything was fine. I'll tell you something else about this particular patient. Every time the patient is a well-educated patient. He's working with the TCS, the Tata Consultancy in corporate, and his father is an Ayurvedic doctor. And I always used to tell them, this is going to happen, that is going to happen. Now we have to do this.
So you're going to treat it conservatively now on.
Next, what do you feel what to do? I can't. I don't have any options. I have to operate. I have to remove this once the infection. Put a flap down and put a definitive internal fixation.
Can I say something, Amit?
Yeah, Sunil.
Amit? Yeah. Now I will remove this fixator, all the implants, everything. I will do it now. The nail down from calcaneus, talus, and fibular nail, and forget about and put a flap on that. That is the only way, because you can't salvage that limb, and the wound will go on draining. If you try to do something and something again, it will go into infected non-Indian or infected ankle. So it's better to do a fusion and with the nail inside, and so that you can have a proper stability on that.
Right. Rajesh, you were half cut. So what is your opinion next?
This is osteomyelitis. This is no doubt about it. But now we have given this history of Ayurveda, and I come from this land of Ayurveda, so I know how they are. They don't allow you to touch, and probably you go and sit on it, and something different happens. So that is what I was expecting, and that is what I'm expecting in this case. Otherwise, scientifically, this screws looks to be infected. The bone looks to be infected. You need to be doing, and I don't think we can do much about the ankle joint.
Right. Sampath?
Yeah, I agree, sir. We have to be very aggressive, and fusion should not be attempted here. First, infection has to be out.
Fusion, you feel this was not pouring pus, but this type of an injury we see quite often. This dry tissue over here and this healing thing.
There is some infection. There has to be some infection.
Yeah.
There has to be some infection. It cannot, the wound cannot just ooze out simply.
It is not oozing. Now it's not oozing.
Some kind of deeper connection.
Maybe, yeah. Sampath, yeah, tell me.
Yeah. So at least that exposed implant should not be seen. I mean, it has to be out.
Correct. Girish?
Yes, sir. The same thing. Control the infection and then the fusion in later stage.
Sushruth?
Same.
Okay.
Same.
Okay. This is 5 months. As Rajesh said, they were not very willing to do any further surgeries. They said, do on your debridements, go ahead with your dressings. Nothing much needs to be done. We are sure. The father, who is an Ayurvedic doctor, he said, I am sure it will heal. This is 7 months. 1 year. Now please comment.
Hey, no, some God that really saved that leg. That should not have happened. Unbelievable that actually occurred. Was he on chronic antibiotics, or what were they doing? How is that not grossly infected? You were staring at the fibular plate for like 7 months.
Yeah, they were sitting on it. The patient started walking at a year, and somehow this is it. What has happened? I'll just go ahead. This is 1 year. I'll show you. This is 3 years post-op. And this is 3 years post-operatively. This is
We have a statement here. We have a statement in
Very-
America: better lucky than good. I
Very
think this is luck, not if you reproduce this 100 times, 90 people are going to lose their leg.
Yeah, probably.
I mean, I think this got lucky. This should not happen. Statistically speaking, and it doesn't happen. You know, we all do. I mean, the reason why I'm gun shy is I do a lot of garbage from the community, and I see a lot of disasters. So I think God bless you, but I do think for the audience, this should not be considered routine outcome. This is a God's
Not
gift.
at all, not at all. This was left to the patient's relatives who denied further surgeries. Now look, in this 3 years follow-up, I can see there is a void over here. You can see this. The loose piece probably has resolved. This one.
Is it still draining?
No, not at all. It's all healed.
Just to barge in, what's your take-home message on this case? And we have to move on because we are losing on time now.
No, the take-home message could be the right time, right decisions, and quick surgery. And probably, if there is an infection, then you have to remove all your implants.
And if I have to ask you, what would you have done differently if it is today?
If it was, even if it was, this is just 2 years back, I would have definitely removed all the implants and gone in for a proper external fixator, continued the external fixator, and done a antibiotic, probably a block or a cement over there, and fuse the joint at a later phase.
Good. Okay. So can you please stop share, and Amit,
Yeah.
we have to jump on, please. Thanks. Great case. Rajesh, are you ready with yours?
Yeah.
In the meantime, can I quickly share my screen and show something interesting here? We are coming ahead with TraumaCon World this time. And so almost around 12 countries are participating, and that's the list of very illustrious faculty, right from US down under Australia. And it's a combination of Trauma Society of India, Austrian Trauma Society, and the OTA, international part of it. And we are there for 2 days, 15th and 16th of August. So this is just for the audience to know what we are doing. And back again, can we start? I will stop share. Okay.
Yeah.
Rajesh?
Yeah. Is the slide visible?
Yes. Slideshow, please.
Yeah. So we've seen some very bad pylon injuries. Let us go for a little more basic injury. 35-year-old male, alleged road traffic accident, closed injury, and no other comorbidities. Girish?
Yes, so as we have discussed, we should always look for the soft tissue first. So what is the soft tissue status?
Some amount of swelling, little bit out of blisters.
Considering this X-ray, it looks like a high velocity injury. So chances of getting soft tissue problems are more if you do the definitive fixation on day one. So I would like to span this this fracture and get the CT scan done.
Wonderful. Any other different opinions than what Girish said?
The first external fixator, then scan.
Perfect. So this is not done by me. This was different. This is referred case. So this was seen by an orthopedic surgeon here, and this is what he did. He found the blisters, and he thought it was a compartment syndrome. He did a fasciotomy, and then he fixed the fracture. Dr. Sampath.
Agreed. So actually, For blisters, we should have gone for external fixator, but now it is added with more instability. I will like to look at the soft tissues, and probably we'll have to redo everything now. And we'll remove everything, but again, soft tissue will be key.
Yeah, yeah. So I think all of us probably, I don't need to ask any panelist. This is absolutely not the right thing. So this is what was done for the AP view. He put this one screw and a wire and one fibula plate, which is again not reduced properly. And for the lateral view, it was again one screw and posterior-anteriorly, and the whole thing was, the tibia was mal-reduced. So what he continued with this treatment, and once the swelling subsided, he had done a fasciotomy, he did a split thickness skin grafting, and 6 weeks down the line, of course, there was a little bit of a serosanguinous discharge, but the bone wall healing was not done, and the patient now has come to us. There is this incisions all around the ankle. Fasciotomy has healed, the split thickness skin graft is healed in the anterolateral aspect, and this is the X-ray. Dr. Ashish, your point of view, what would you do now? You have incisions all around.
So incisions all around. First, yeah, ruling out the infection, like, basic.
Blood parameters are on the borderline, nothing much, no direct signs of any infections now.
Yeah, I mean, that's one. Then, like, I would definitely do the CT scan here for sure. I doubt that, I will go behind, salvaging this one at this point. I don't know, but I might change my opinion depending upon what the CT scan comes. But one message I want to convey to all of you, I look at all of the peel-on fractures. I know there were open fractures. There were pretty challenging cases. But in the past, when I saw the peel-on fracture open reduction internal fixation done with just like, screws and just a K-wires, I'm not talking about the cases discussed today. I'm talking about the closed cases. And one thing we have to understand, this is high velocity trauma, not along with the soft tissue. You need the definitive rigid fixation with the longer lever arm. I mean, Rajesh, I've seen yours and Sampath and other people's work. I mean, you guys do great fixation with the bigger plates, like, securing medial, lateral, posterior, depending upon its need. But that's needed. Here you can see how it turned disastrous with the minimal fixation.
Yeah. Dr. Sunil, your take, what would you do now?
Now we have to realign by taking into soft tissues. Now you have to take it off. If there is no infection, then you have to plan in properly such a way that you should not get any further wound adhesions. So looking at the incision, the anterolateral is a workhorse. So what we have to plan is
lateral is the way the fasciotomy wound is.
Exactly, but that is healed now. Is it completely? There is no any CRP is not raised. Everything is not raised.
Yeah,
so you have to now. There is no way that we have already. You have to fuse it because and the realign it. So you need to get a good realignment because the talus is already subluxated. All right. So either you have to get a good compress with the two fragments with the compression, and if at all there is a posteriorly, if there is a space available, we can put a posterior plate and compress that, a small plate and compress that, and create a good plafond to get a good fusion. That is the only way in future.
So what about fibula?
Fibula is fine. Let it be. It is aligned.
Sunil, that anterior
maybe rotated. The fibula may be rotated. We don't see the proper view. We can see the rotation of the fibula, but it doesn't matter now because we are going to fuse it. So rotation of the fibula is to when you want to salvage the ankle. When everything is going to fuse, there is impaction. the internal impact is already there, which is healed and infected. So probably we have to fuse it.
The fibula is angulated posteriorly and the talus is translated nearly 100% anterior to the tibia. Fibula, the plate has to come out so you can get that ankle back. Even if you're going to fuse it, fibula has to come out. I mean, that ankle is translated 100% anteriorly.
The ankle, the fibula is actually fixed in a little bit of a shortened way. I mean, it is not fixed properly.
Yeah, that's true. That's true.
Short is not the issue. It's the angle.
Angle is
You
not
can't leave the fibula with that much posterior angulation. The talus will remain anteriorly translated. It has to come out. Revise is a different deal, but it has to come out. At least you have to put the talus under the tibia.
Sure.
Anterior widening of the joint you can see over there anteriorly. That indicates that definitely the fibula is not fixed properly, and the syndesmosis is not corrected. So what I feel is that you have to get a correct fibular alignment and a proper fibular plating, for which you require a revision of the fibular plate.
So what will you do? What will you do? Dr. Amit, what will you do?
Okay. I would definitely go down and revise all these things, but then this fasciotomy is anterolateral, you mean to say, na?
Yeah,
this
lateral.
is anterolateral.
Lateral. Yeah, lateral.
Okay. Then probably the a posterior lateral incision, wherein you can fix the fibula plate as well as you can fix the posterior malleolus. The typical posterior malleolus incision which we do otherwise, you can go posteriorly and fix and maybe you can realign your tibia as well as the posterior malleolus. You can put a plate in the tibia, you can put a plate in the fibula from the posterior incision in the prone position.
Dr. Sushruth? Is not here. So, Dr. Sampath, would you have any difference of opinion?
No.
Yeah. So I'll go forward. So this is, as everybody is agreed on it, fibula is not aligned properly. It is rotated. The length is not there. So the implant has to come out. Of course, the tibia is absolutely haywire, so everything has to come out. So what was wrong here is, first of all, the CT was not done. The timing of the surgery, it was just a blister. First, we have to understand tibial plafond injuries will not have compartment. It is usually the soft tissue damage, and you don't need to do any fasciotomy. You just have to keep the limb elevated or put an X-fix and keep the limb elevated, and wait for the wrinkle sign to come. It is an intra-articular fracture, non-anatomical reduction, and non-stable fixation. So everything was wrong here, right from the soft tissue handling to the bony handling. So this is what I said. Everywhere the incisions are there. What next? So wound debridement and external fixator was done. Removed everything. All the implants were out, and this is how it looked like now. Dr. Anish, what would you do now?
I think you did the right thing. You take it all out. In this case, I would accept the fact that this joint, even if you try to salvage, is going to be arthritic and non-functional. So my thought would be to plan to leave the X-Fix on for a few weeks, make sure everything is healed, make sure that lateral wound properly heals, not quasi heals, and then do an ankle fusion. I don't think you need to do TTC, but the benefit of TTC is that you can make a small incision, destroy the joint, shoot the nail up, and you'd get tibial fixation as well as you fix the metadaphyseal junction, or you can use a massive plate. The only downside of a massive plate is a lot of soft tissue dissection. So I think, although I don't like taking the subtalar joint, a TTC would be my final salvage to get the joint fused and fix the fracture. I wouldn't worry about the fibula anymore. I would not try to salvage this person's ankle, because even if you salvage it, it's not going to be functional. But I'd wait a few weeks.
Dr. Ashish, you are on the American side?
Yeah, I will wait for a few more weeks, like, everything healed, the infection marker, everything normal. In my practice lately, in the last few years, when patient operated like this with the open fractures or the open injuries, if the subtalar joint is reasonable, I go with the arthroscopic ankle fusion to preserve the vascularity, and I'm considering the population that we are treating, poor vascularity,
What
smoking.
about this one?
So I will do arthroscopic ankle. I will attempt, but I know that
What about the shaft, the proximal shaft? It's still not united. It's still not.
the proximal, the posterior part is not united, but like again, I as I mentioned, like here, I will not jump over it for at least 3 months here. But I agree, the posteriorly with the CT scan, if the posterior fragment is not united, lateral, then it's a lateral approach, taking the fibula down and going with the fixation, but going with the consent of ankle fusion versus TTC fusion, depending upon how much, how much opposing bony surface I'm getting here.
So you also would go for fusion. So let's hear about the Indian scenario now, Dr. Sampath.
Yeah, agreed. Issue is soft tissues around. So I'll like to have plastic surgeon's opinion whether any angiosome is left to approach. If at all, I can approach posterolaterally and address that posterior plafond fragment, then only we'll be able to save the joint. But issue,
I don't have the CT, but the CT shows that there's not much of union.
yeah, I mean, only issue is soft tissue corridors. So I will discuss with the plastic surgeon. If there are soft tissue corridors available, then we'll think of joint salvage. Otherwise, maybe ankle fusion transfibular will also be a good choice.
Dr. Shushruth, what would you be doing?
I think if the infection is not there anymore, and if you are convinced that there is no infection, the skin planes, once we decide, try to avoid those scarring and fasciotomy skin incisions and fix it. I would still want to salvage this, I'm still not convinced that he is landing up with fusion. I would salvage this.
Dr. Sunil, salvage or fusion?
If you see the lateral view of your own X-ray, there is a huge gap. So, so many, how many months? 2 months almost.
2 months now.
Yeah, so almost 2 months, there is a gap. So I don't think you can able to salvage, and the patient is ready for multiple surgeries again and again. It is not feasible to do. I think we should go with a good fusion, and the patient can walk earlier and faster. Because already the impacted fracture and maybe some sort of infection is added. So we don't have any other chances again.
So we have 3 for fusion, 2 for salvage. Girish and Girish, one word answer: salvage or fusion?
If you are putting an Indian situation, then salvage, all fixation.
This is of course Indian.
Using posterior.
Okay.
Only one.
You are in Nagpur, India.
He has mentioned the Indian situation. That means you want joint. Anyhow, you want joint. So one option, all posterior.
Last, it's your turn. Salvage or fusion? Dr. Amit?
Yeah, Rajesh, this external fixator is there for quite a long time, you mean to say. But then you never thought of correcting that ankle congruity? Hello? Congruity, because those rods are actually coming in the way of your ankle in the X-ray. You can't see the lateral ankle congruity. Posterior malleolus seems to be out of the joint. Yeah. So there, probably over there, before while putting the external fixator, I would really have done something to the posterior malleolus, because that ankle congruity is very important. Now that it is already 2 months and 3 months, I will definitely try to salvage, no question about it. But then while salvaging, if I'll keep the fusion material also on table, because if it is not possible.
You know what we have till now not talked about, Rajesh, is taking an entire posterior approach.
Yeah.
I agree, your anterior is fired, anteromedial is fired, anterior is fired. take an entire posterolateral approach and do everything by posterolateral.
Yes, Sushrut, I told him that posterolateral, approach the fibula, approach your ankle through the posterolateral approach.
Everything
You'll
posterior.
get everything done.
You still have your posterior.
Yeah.
Even someone said the same thing. If that's a window available, we'll go for posterolateral. So
Posterolateral, yeah.
this, and that is what we are discussing. So this is what was done entirely from the posterolateral approach. The single approach, posterolateral, both tibia and fibula was fixed. The humerus plate was used. The proximal humerus plate was used, and so this is how it is the follow-up.
Only one thing, Rajesh.
Yeah.
When you have gone posterolaterally, why do you have to put your fibula plate laterally?
Laterally, yeah. Why not posteriorly?
Flat surface of fibula.
This is actually posterolateral. It's the view point. It is posterolateral. It is not exactly the lateral. It's just that window opening. When you open the window, it is
okay. But you did it from that posterior approach only. From one approach, you did both the platings.
You can see the state.
Yeah.
Yeah.
Very good. Okay, one question allowed, Rajesh. Then we have to move on, buddy.
Yeah.
One question. Yeah. You pick and choose.
I mean, the whole idea in this was, I mean, we've already had questions. A whole idea between Indian scenario and American scenario we've been seeing in the whole discussion is both Dr. Ashish as well as Anish were talking more about fusions, and we've been talking more about salvage. A basic difference of opinion is there, but whatever the thing is, I think the principles has to be followed, and whenever the principles have been followed, everything goes on well. So that is what my point of view was with this view. The principles were not followed in the initial one, and once they were followed, we could salvage and we could give some movement to the ankle. Of course, we don't know how much of arthritis the rest of the in future it might happen, but at present we've given a workable ankle.
Yeah. Sure. Sunil, you want to ask something quick? Okay, let's move on. Let's move to the next case. Anish, are you ready? So,
yes, sir.
Great to have you, Anish. Anish Kadakia from Michigan.
I moved now. Years ago, I'm now at Northwestern. So that's not that anybody, you guys care. It's the same distance for you. But now I'm at Northwestern, and I just got promoted to full professor. So whatever that's worth. Wasted my life.
Where is this? Northwestern, just to increase our general knowledge?
In Chicago.
Chicago, okay.
Downtown Chicago.
All right.
That's my hospital in the background. So, you know, I know we're talking about revision Pilon, and, you know, it's interesting. And I guess in India, you guys, Indians in India tolerate. Now, once they move to America, they completely change. Indians in America cannot tolerate a toenail problem. Oh, it hurts. Oh, what are you going to do? I don't know what the hell happens on the plane, but I swear to God, it is not like you guys. I'm dead serious. Ashish can tell me the same thing. And Girish hung out with me. Our patients, Americans, we complain about everything. So, different mentality. So here, you guys showed some amazing cases. And I think, you know, the articular surface never looks great, but if they can tolerate it, why fuse it? But this guy came in from an outside hospital, had an anterior ankle wound. He felt something wasn't right, as they do in this country, wanted a second opinion. It was red, swollen, and clearly infected. So that's the metal. The original x-rays I don't have. It was a closed injury. And he shows up with these massive plates, large anterior anterolateral incision, and a medial incision, as you would expect. So what are your options? He's 50 years old, hypertension, active. That's it, nothing else wrong. Girish, and then I'll go around. What are you going to do for this guy?
Sir, I would just want to ask whether the anterior ankle wound is infected. Is there any discharge from the wound? And what was the main complaint of the patient?
There was a hole in the front of his ankle and it was draining. And his doctor kept saying, see what happens.
All right. So,
red, draining wound, Clearly infected. Don't even
Considering
guarantee disinfected.
considering this situation with the implants in situ, it definitely give you the idea about the osteomyelitis and the ongoing infection around the implants. Uh, so if there is a continuous discharge, we need more workup to label this case as an infection, and we need to definitely plan for the implant removal, uh, antibiotic beads if you want, and the stabilization using the external fixator if it is unstable.
Okay. Sunil, anything different? So
Yeah,
labs are high, CRP is high, ESR is high,
So it's
all infected.
a 6 months whether you are able to remove these locking plates, because all this is I presume it's in the United States must be stainless steel, isn't it? Not titanium,
They're all steel.
all steel. So you can remove these plates, debride it, because it must be united. 6 months means the fracture is united. Must be a clause of some sort of osteomyelitis or something like that. We have to treat as osteomyelitis rather than to have. So you can remove the implant and just see what is exactly is happening.
Okay, so I know we're running late on time. I'll go down the rest of the panel. So we did that, what you said. We went through all of his decisions, cleaned it all up. We put a big cement spacer in there, more cultures, and he's got MSSA. Next step, Shutrut, what are you doing? Shutrut.
I'm in trouble, I know. So the
No
question is,
Ayurvedic guy to help anybody here, okay? You cannot call on them. They don't exist. Not here, man.
so I will wait till it settles down based on MSSA. We'll take a look at the protocol. Every hospital has their own protocols. But I hope this settles down. But I know this ankle is heading for fusion. So I will be trying to prepare mind of the patient and the relatives to head for the fusion. Fusion once achieved, whether done arthroscopically or open, will probably also control the infection, I hope. So fusion is the ultimate end of this case.
So, Amit, you're gonna, he says to do fusion. Can you do that with the bone stock that you have? The whole anterior lateral tibia is missing now.
Yeah. But the rest of the fractures all had healed.
The posterior aspect is healed. The front fractures are in the garbage can.
No, it's very difficult over here. And you put this antibiotic cement over there?
Yes.
Okay. But do you expect any sort of masculine membrane or something over there to come?
You can do that if you choose. It was not my intention, but that is, cement spacer can be done for masculine, but it's not how I do things.
No, definitely I'll go ahead with a graft over there. Maybe the fibula, we can put it in there in that anterior space and add proper plates. I would not go in for a calcaneotibial rod. I would do a plating in this case for fusion, along with the cancellous grafts.
Okay. And then nothing for the soft tissue. Soft tissue can close, it's very tight.
If at all soft tissue doesn't close, then add some maybe antibiotic beads again over there and a vac dressing. I think soft tissues should close over there.
Sampat, same idea?
Yeah, I mean, first thing is to get rid of infection and take care of the soft tissues, and then think of about the joint. But first is get rid of infection.
Okay, so I think we have everybody's ideas. Get rid of infection, some sort of fusion. Who would do TTC? Ashish, would you do TTC and something different?
I would do TTC in this patient, considering anteriorly after the flap surgery and everything is done. In my hands, like, I do that like at least a couple of times a year. I use a fibula as a strut graft and just do from calcaneus to tibia to talus. I'm able to get the results in patients with the multiple non-unions or the patient with the infected patients in the past. I know a couple of patients mine have done disaster with that as well, you know. But in this case, given case, I'll be more inclined towards after everything healed, the fibula strut grafting and fusion.
So I like that idea. It didn't occur to me to do a fibular strut graft. We have the luxury at my institution of femoral head allograft. So I called this the snowman. So I did a double femoral head allograft reconstruction with a nail. We take his concentrated bone marrow. We did an anterolateral flap to fix the soft tissue. Because I did not think I could just shove it over, but it probably could have done tight, but I have a good plastic surgeon. So I took 2 femoral heads, I stacked them, which I don't think is done in the literature because it doesn't seem like a good idea. And then I pinned them from A to P and he ended up healing. So that's his 1 year post-op x-ray. So we did the femoral heads, we took everything out, it was clean, pinned the A to P, and then I did a TTC fusion because I didn't want to go back up and put a huge plate on this guy. I do think a fibular strut would have been much more logical and much more available to everyone instead of this expensive femoral head. And I don't think these people, they're stiff no matter what they do. And I do have a CT, so you don't believe anything in this world. But these are CTs out a year. That whole thing healed.
Oh, wow.
There's no question.
The
Any
femoral
comments?
The femoral head junction and the tibia. Has it healed?
Yeah, the whole thing healed.
Okay.
When I did it, I thought it was stupid. Because I opened it up and I realized, I'll tell you, in the operating room, I realized my femoral head wasn't long enough. And I swore a little bit and I had no good options at this point. It didn't occur to me to take the fibula. That would have been smarter. Pre-op plan would have been fibula to transpose. I would say in hindsight, that's what I would do next time. But this worked. Obviously, I got lucky. But I do think the flap helps because I put brand new, beautiful soft tissue on. The chance of them the chance of healing is improved. Even if this was not a vascularized medial femoral condyle, which I do as well. This is just a soft tissue flap. And I think in the setting of nasty infection, poor soft tissue, poor arterial flow, all of that is given an infection that if you can flap them, you can get these things to heal. I haven't done 100 of these. We're publishing on this concept, but it does seem to work. The guy does not need amputation, but fibular autograft would have been a better idea.
Yeah,
How did you fix that femoral head? Nothing,
Yeah.
just
Nail.
face fit.
Nail in the KYs from front to back.
All right.
But was that enough for a fusion? Because I thought that a plating would have been better over here.
Well, it's enough because it's healed at a year on CT.
Yeah,
so
now
answer is
now
yes.
that it has healed, it's fine. It looks good now. But with K-wire fixations for arthrodesis, it would be a bit flimsy, no?
First of all, I've seen K-wires all day today and everybody else's x-rays. So to give me business about K-wires, dangerous game. I'm a nice guy, but I'm not a softie, okay?
You hit a good first
The overall fixation is the nail, okay? The K-wires are holding the graft from A to P to the intact posterior tibia. You can use screws. However, using screws in an allograft can cause stress riser and fracture. I've seen that a lot, and that is why I use K-wires. This is a definite, I went for a grand slam, and I got very lucky. This could easily end in amputation. I agree.
Anish sir, one question.
But to put a huge plate is also a downside that you have, again, and now a massive soft tissue dissection. And my goal was not to do that again to this guy. Because if he gets amputation, that's an unfortunate outcome. Nails are great because you don't have to worry about it. I'll do one more case because I know everybody only get to do one. Slightly different, less severe than what you guys have. So a different animal. Lower energy injury, had a pilon fracture, lower grade. The person that fixed it like this. So they did a nail for a distal tibial pilon fracture, but really in the end missed the pilon. Put a simple screw, and now this guy is in varus and has his anterior subluxation. So, Rajesh, what are you going to do? What would you have done differently? Is this how you fix your distal pilon fractures? Do you do, this guy had a really distal fracture, you can see as a medial, it's easier for me because I did the case, but I'll tell you, it was a medial vertical fragment of the distal tibia, the anterolateral fracture as well, and obviously a shaft. So would you have done a nail with the plate instead? What do you do differently for this?
I
So
would
this doesn't
definitely
happen.
go for only plate. I would never put a nail in this because to get a distal fragment fixation with a nail would be very difficult. Even if you have some nails which has got the distal most fixation, many a times because of the fracture fragmentations in the different directions, since the nail screws are fixed only either anteroposterior or lateral, so you might not get all the fragments. So I would definitely not think about a nail in such type of Plafond fractures. I would definitely think about plate itself. What type of plate would depend upon the CT scan and the fracture pattern.
Fair. Now, I don't have his original stuff. They only show up like this to the office. Would anyone on the panel nail this and then do some sort of MIS articular reduction? No. Okay. So now you're stuck with this, right? He shows up to your office. He's 32 years old. Rajesh, what are you going to tell this guy? You're going to fuse him, replace his ankle. You're going to try to salvage this. He's about 1 year out now.
How old is the injury and now?
1 year.
1 year. So the fractures have healed.
Fractures are solidly healed. He's 1 year out and it hurts.
I'd probably go for a two-stage in this thing. I would remove the implant first, and then I would plan for a supramal osteotomy and correct the inclination to prevent the future problems.
So you do want to do a SMO. You're going to do the whole thing extra articular. He has, I'll show you the CT. It's hard to understand, but a CT shows this articular defect on the sagittal. So he has his anterior impaction, and on the coronal, he has vertical impaction. And you want to do an extra articular osteotomy or something different?
Now the scenario has changed. Before that, articular surface was intact.
Yep, I thought the same thing like you. So now I got this, and I was like, oh, crap.
Yes. Anyway, I would probably, the funny thing about ankle is many a times we think ankles are unsalvageable, but they do get salvaged. I'd probably scope the ankle, have a look on the cartilage, and then decide whether I can still go for supramal by decompressing the thing. If the articular surface is completely damaged, then I'll go for a fusion.
Okay. Sampat, would you do anything different? Salvage this guy?
I mean, if there is obviously pain which is significant at my hands, fusion, I mean, I will conserve till he can tolerate, but really ankle replacement we don't offer. So when he demands, its fusion is the answer for us.
Okay.
Why I said is because of some papers by Hinterman's public. I mean, if you look at it, he has done the supramal osteotomy and has kind of produced some fantastic results. So that is what I thought about.
Very reasonable. Girish, are you going to salvage this with some Hinterman type SMO? And if you know Beat Hinterman, be careful what you read, okay?
Yeah. So if I will discuss this situation with the patient, and if he is not willing for the fusion, and if he anyhow he want to save the joints because the deformity is only in the one plane, only the coronal plane deformity, and the articular step up is not very bad. So intra-articular osteotomy, oblique open wedge osteotomy may give you the good varus correction with the preservation of the cartilage maybe for a few years, because this is an asymmetric arthritis and the patient is young. So you may give a few more years, maybe 5 to 10 years of the pain-free ankle or with the with some discomfort.
It's hard for you guys to see, but look at the lateral. The anterior tibia is not one plane. The anterior tibia is subluxated proximally. It's not a simple, it's easy for me, I did it, but it's a two plane. He has a whole anterior impaction and his medial side is up. So, of course, brother.
Yeah, you have to take a mechanical axis, the orthorodontogram first, to whether how much is the deformity, number one. Number two, You can do a MRI or a arthroscopic assisted. You have to see the examine whether the cartilage is, how much the cartilage is damaged, whether the cartilage has recovered, whatever the damage has. And if there is not much of damage, then you can just leave him or just do a mosaic plasty or oats or something like that. But if it is really deformed and really there is a cleavage, you can do a osteotomy and bring down. There is, forget about that. Just bring down with the osteotomy. The anterior.
Bring down what?
Bring down
what?
And the cover, how much is the cover is missing on the talus. If you see there is a talus is uncovered on the anterior side. So bring down the osteotomy down there. But first you have to see the mechanical axis correction.
All right, fair enough. So
Quick word, can
I will salvage it. So he had a weird, I basically undid his fractures. He had the medial vertical fracture and he had that anterior fracture that Sunil's talking about that causes that impaction. You can see here, it kind of looks, one part is the vertical aspect is high, causing his varus. He has tibial vera as well. It's a goofy situation. His shaft fracture healed in varus, his distal fracture healed proximally, and his anterior tibia healed proximal. So I told the guy I didn't get long leg films because that is stage 2 for me. He needed to have his articular surface reduced. If that was salvageable, then the question is, what do you do about his deformity at the tibia? So I did a vertical osteotomy. I used a distractor, pushed it back down. So I got alignment, put K-wires across, and then I plated the medial side. And then laterally on the sagittal, this is the problem that I thought. That's why I didn't do SMO, which people have mentioned. SMO I thought was a good idea, but the problem is he had a second, that articular surface was smashed up high. So I did an intra-articular osteotomy and I missed. This is my fault. I'm not telling you I'm perfect. I made my K-wire and I made my cut on the wrong side. My K-wire cut should have ended up here. I was trying to correct that whole defect. But regardless, as Sunil said, if you restore the anatomy and so I put that distal piece back down, I put a wedge inside, there's an allograft I put in there to restore his alignment. And I thought this concept is what a lot of people said, you can salvage it. And that was the intraoperative correction. It looked like an ankle when I was done. Did not touch the fibula. And my plan is, theoretically, I can go fix his tibia later. I did not scope it. It looked like, because the cartilage I figured was not going to look great, but it wasn't gone. So I said, I'll just go with God and see what happens. Ashish, would you do anything different, man?
Yeah, I mean, the thing is, it looks pretty good here. If the patient that I'm treating is the good, what we call, contributing to the society.
He's a tax-paying citizen.
Yes. So I would definitely attempt this, but that being at the university in Alabama, I mean, if this type of patient, when they are coming, hey, I want them to get back to how can I use the least number of healthcare dollars, then I throw the arthroscopic ankle fusion in some of those cases as well.
I think that's a great point. So he is a functioning member of society who will do something with his life and is not going to sit at home on disability. That's a big difference. If they're going to do nothing and they're not going to do anything, the goal is not to get infection and amputation. So he's now 3 months out. I don't have great follow-up yet. I just saw him again, but he's happy as hell. The ankle moves beautifully. The x-rays look good. It's healing, not healed, impossible to tell you. I did get a CT scan that shows some early healing, not perfect. So hopefully it won't fall apart. But the concept that people have said is, I think, reasonable to understand that in these cases, the articular surface wasn't destroyed. You can try to salvage even 1 year out if you restore the alignment, and Hinterman has shown this, and Knapp and Espinoza, that if you realign, they do okay. But he still needs a tibial osteotomy. Truth is, that is correct. But I didn't want to do everything at once.
Yeah.
One question over here, Amit. Here. Can I ask you a question?
Of course.
So, yeah. The medial plate is probably the proximal humerus plate, is it?
No, these are anatomic distal tibial plates that we use.
Okay. Now, if you do go higher and do a tibial osteotomy to correct the tibial deformity, then you will have to change the whole thing, the medial side, the plate.
Yeah, so for me, I would have this go to a friend of mine that does a Lizarov correction and have him do it that way. I would not do a diaphyseal osteotomy with metal. For me, looking at some of the literature that I've read, they would do better with a mid shaft, not mid shaft, but at the cora, but a more Lizarov correction, because to take the hardware out, go ahead and re-break it and do another internal fixation with more devascularization, I don't think is a good idea for this guy.
Yeah. Again, one more thing, that small plate anteriorly, which has put, so that there's only one screw holding that fragment which has been osteotomized, and that other screw is from extra plate. Through the plate buttressing, there's only one screw. Did you not think of putting one more screw or extending the plate or a longer?
No, it's a great question. I did not think I had to do this in the case, and so I did not have the right implants available to me. So this is Arthrex's system, and you are correct. A better option would have been a nice T-plate, but I didn't have it at my time, so I put that screw outside the plate, and then I put that. It's a little midget recon plate, so it's got some stoutness to it. And so I thought it was functional enough, but you're 100% correct. That is not ideal. I wanted to go longer, but there was nothing I had sitting that would work.
That's good. Excellent.
Looks really good.
That's it for me.
That's great.
Okay, thanks. Great. Anish, terrific.
Thanks, guys.
Let's move on. Anish, if you can stop sharing your screen, please. And next is Ashisha. It's incredible to have you guys from US, really. Waking up at 4 o'clock in the morning shows the zeal to share the knowledge. Ashish, are you up with your case?
Yes, I'm here. Thank you.
Good.
Yeah, so I was not prepared. Like, and in the morning, I saw the WhatsApp message. Hey, everybody's like, doing the case. I pull up from from the backlog, and looks like this will be the easiest case that I'll be presenting. Easiest couple of basically to more of convey the message to the audience, that hey, do the complex, but at the same time, don't forget the principles. Okay, so just a sec. So I'm Ashisha. I work at the University of Alabama, Birmingham, and I'm here for last 10 years. And I was fortunate to have Girish as well as Rajesh at our place. Yes. Okay. Okay, great. So this is 33-year-old, just a sec. 33-year-old Caucasian female came with severe pain in right ankle for last 2 years. Is not able to work for the last 9 months, secondary pain. She was operated for Plafond fracture 2.5 years ago, and arthroscopic debridement ankle 8 months ago. And basically this is what she comes with. The severe tiredness, normal examination, neurovascular. I mean, she's afraid to put full body weight on it, restricted ankle motion, no tenderness on the subtalar joint. And this is what it looks like. Girish, what would you do here for this patient? Patient is in your clinic.
Yes, sir. So according to the history you said, and the pain in the ankle 2 years down the line after the intra-articular injury, we need to find out what is the pain generating area here. Definitely some sclerosis around the joint line and the asymmetric joint line narrowing in the sagittal section, and maybe the anterior tibiotalar impingement and the dorsal osteophytes are visible there. So probably ankle arthritis is a cause of pain, but I would like to look more in the clinical examination and CT examination.
Yes, so clinical examination, she had pretty reasonable woman, again, functional part of the society. She wanted to go back to work. And basically, she doesn't want pain medication. So that's the first test, we do. they ask for the pain medication, it's coming from something different, like, so the whole anterior, pretty much, you can see she was more like plantar flex, restricted motion, pretty much zero motion, you can say, is coming down to like fixed into 5 to 10 degree frequency. So I agree, you do CT scan here to get more. Rajesh, if you can say anything else, what should you do differently here?
To start with, I think this was a kind of an intra-articular fracture, a low energy pylon, which was possibly missed during the first surgery. So there is a little bit, if you look at the towards the anterolateral aspect, there is a defect there. If whatever I can see from the X-rays, so possibly there is an anterolateral pain, impingement possibly, and or an articular damage there. So I mean something which will clinical examination and of course CT would be of beneficial to plan out, because we're looking at an arthritic changes, early arthritic changes in the ankle.
Yep, so yeah, this is the message that we need to convey to, and that's what we discussed for the last few cases. Like just doing the screw fix. One is the importance of CT scan after this type of injury is must. I know a number of times, like, when we are presenting, we say, hey, patient could not afford. If the patient can afford the surgery, we can spend some dollars or some rupees from that surgery part for CT scan to get better understanding. Number two, the fixation. This was done like rural part of Alabama. The general orthopedic surgeon did not diagnose this pilon fracture. He just put the percutaneous screw fixation here. I don't have the X-rays before just after the injury, but Rajesh pointed out rightly, so here it needed, the pilon fracture is not only you do the screw fixation, K-wire fixation, you need to have definite fixation if the conditions are permissible. So this is where we are with the full-blown arthritis. Anybody will just go and just shave off the anterior ankle impingement. Dr. Amit, would you do anything differently here? Let's say the CT scan shows good amount of ankle arthritis, is a bone on bone. Arthroscopy is already done by some general orthopedic surgeon. Now this patient is in your clinic.
Unmute, Amit.
Can you put your screen on a full screen?
Just a sec.
Because the image is seen smaller than.
Okay. Is it good?
Yeah, that's nice.
Thank you.
Okay. Now this is clearly a look at and syndesmotic problem over there. That is what I feel. And the fibula has really gone too posterior, and that anterolateral fragment which was loose, and you can see in the ankle mortised view, the anterolaterally, that small tibial fragment is coming more laterally, and it is impinging more over there. So of course a CT scan first, and getting more knowledge about the articular fragments and also the fibula and its incisura. And once we get that, I think I will try again to salvage this, get your fragments over there corrected, and probably get some fixation over there.
Okay, this is 2.5 years, and if I say a CT scan shows full-blown, like, arthritis, it's not the, and you can see even from the X-ray, it's pretty fairly visible. That
it is visible. The talus is quite arthritic. Yes. But for us, I'm talking about the Indian scenario. Our patients really go on and walk with all these things. And if at all they really, your patient will not tolerate this, and some amount of pain is also not tolerated, then you have to go in and fuse this joint.
Okay. So again, like we do X-ray, CT scan, X-ray, MRI, but considering with the hardware, we prefer X-ray, CT scan here. I apologize that I don't have the CT scan here, but as I mentioned, it was full-blown ankle arthritis in this patient, 33-year-old. Sampath, would you choose any of this option or something else differently that you will come up with in this patient? Or
I will first explain him about conservative treatment, and if at all with rocker bottom shoes he can buy some time, he can. Otherwise, at my hands, I will go for arthroscopic ankle fusion.
Arthroscopic ankle fusion. Anybody will try the distraction arthroplasty or heard about it?
What about osteotomy anteriorly, just to correct the alignment?
Yes, we thought, like, I'm sorry, I don't have just a CT scan here. It was full-blown arthritis here. I mean, that's what, like, we gave consideration. It's possible, but even there was so much cystic changes throughout the joint. And the patient now, she was fed up with, because she already had 3 surgeries. And she said, hey, I want one time and I want to be out of your clinic, So that's why it's not a choice here. I wish I had put the CT scan here. I mean, Anish, do you do distraction arthroplasty of ankle, or?
I did it a couple times at Michigan because it was hot when I was young, and it was terrible. It didn't work. It was a nightmare. And then the literature kept coming out, at least in the States, it doesn't work as well. My understanding is if you want to do it, you should think about it carefully. Ilizarov or ring fixator, and make sure you have a properly positioned hinge to get the ankle moving. If you don't do it that way, you have no chance of doing it. And even then, people say it takes up to 5 years to get relief. So unless it's that very unique 22-year-old military crazy person that refuses anything else, most people will not do well. But if you're going to do that, you don't do that out of curiosity. You think about that, go to a course, and then do it properly. And I tried it, it's a failure, and most Americans don't. But you should know that it actually is a reasonable option in an extremely difficult case. You got to follow the principles perfectly. Ashish didn't like my answer and turned his computer off.
He lost his broad imaging. Internet. Shushut?
Yeah, I think
Internet
network. Shall we just move on to the next one?
Yes, but he has to de-share. No?
Yeah, I'll text him now.
Sorry, something happened to laptop. My Apple died, so, but until the time I'm just connecting through the phone. I totally agree with Anish. The distraction arthroplasty, it looks pretty good on the paper or on the when people are saying about, but even if you look at the literature, the couple of papers from NYU or just George Pellis Institute, other than that, nobody's able to come up with any good results. So in this patient, I'm sorry, I'm not able to. Let me see if I can share here. I did the arthroscopic ankle fusion in her case, and she was back to like work pretty much like 3.5 months from the surgery. So message that I'm trying to convey here is basically, number one, we need to make sure what we are offering to this patient. When CT scan is must. Number two, the type of the fixation is like, the type of fixation. Don't go with just, I understand that the traditional teaching or learning in different part of the world is a little different. I grew up in India, and I was also the KWAD as well as the screw fixation guy for a number of things. But at the same time, when I see like Rajesh's x-rays as well as Sampath's or the Girish's x-ray, it makes me to feel proud of like, hey, you guys are following some what we call the principle of fixation, which is very important, And I know we physicians are very good in communication in India, specifically Indian physicians. We keep them updated. Hey, it's may not heal, will heal, this, but you look inside your heart like, hey, what am I offering? Is it good? I mean, is it going to work? That's a way more important thing than being upfront with the patient, say, hey, you are going to get possible union, non-union and stuff. So, I mean, this is it. I'm sorry. I will be glad to share the last few slides in an email.
That's perfect. All right, Ashish, we trust you. We believe you. Don't worry.
And not that, just for the completion of the presentation.
I understand. I understand. So let's move on with this. Sampath, rather than showing a case, can I ask you in next 10 minutes to sum up the entire foot and ankle session and just give the audience take home messages, what we learned from each case, and just talk to us for next 10 minutes, because I've been asked to evacuate the stage in next 10 minutes. So
Sure.
please.
Sure. So most important point is actually a pilon or tibial plafond injury is a soft tissue injury that we have to understand. And any decision making, the key point is soft tissues, and soft tissues. So we have to base our decisions on soft tissues. Second important take-home message is don't get committed for the fibula in initial part of pilon fixation. If you get committed, then you're blocking your next plans to make the soft tissue corridors. So important is span. So first reduce, scan, and then plan. And planning is all about soft tissue corridors, implant of choice, and implant of choice. They are thin profile implants. If you land up in issues, soft tissue issues, then again thorough debridement and early soft tissue coverage. So,
can I ask you something, Sampath?
Yes.
Which will be that case wherein, as Sunil suggested and as Amit showed, which will be that case wherein you would consider primary fusion in our Indian patients, and so radiologically and soft tissue wise, what will be that case wherein you would suggest that, okay, no, there is no point in going ahead with any attempt of skeletal reconstruction or soft tissue, whatever?
Okay, that's a very good question. I wanted to answer that. Now, in Indian scenario, primary fusion is taken very wrongly. In fact, to do primary fusion, you require a lot of expertise, because fusion is first is realignment, getting a good bone stock, and then fusion. So, in a primary situation, when there are flailed pieces of bones in a comminuted scenario, to prepare that joint is also not very easy. So, in safe hands, in beginners' hands, even it is better to realign first, get the alignment right, preserve the soft tissues, and even at second stage, you can go for fusion. But if you are an experienced person, then consider primary fusion. But to decide that primarily, there is no need to go for day one surgery. Even primary fusion is said even if you go for after 2 weeks or 3 weeks. So primary fusion needs little expertise. You can go ahead in a comminuted scenario where you feel that reconstruction is not possible, but keep it in mind, even for fusion, you need alignment, you need biomechanics, and you need to keep soft tissues intact.
And bony pieces to get that union. Even a 50 years of experienced person cannot unite that bone within 5 days. So you need to have a proper bones to unite that, because you are dealing with the talus cartilage. We are going to, it's a solid bone which takes a lot of time to heal. So it is better to delay for 2 months at least for primary ankle fusion. Even what you said is absolutely right. Alignment very important. There the play of external fixators. We have to use maximum external fixators to span the ankle joints.
Alignment, bone stock, and soft tissues.
I was hoping to see someone show us role of 3D printing in tibial plafond, especially Anisha's case, brilliant case. I think 3D printing that we use left, right, center for proximal tibia and proximal femur. When there is a multi-planar, multi-directional involvement of bones, intra-articular involvement, something happening also in the tibial shaft level, where to do osteotomy, how to do osteotomy, which plane to choose. I think 3D printing, very easily available to every one of us here, will definitely direct us towards deciding the level and plane of osteotomy, and then maybe, Anish, we can do everything in one go. Use a longer plate, but do an intra-articular osteotomy and tibial varus correcting rotational osteotomy in a single go, maybe.
No, I think it's a great idea. My friend out of Switzerland, Norman Espinoza, when he was at the university, was doing that 3D printing, creating cutting guides, and then having the custom plates designed for that osteotomy. If you all have that ability, it was what he showed was brilliant. In the States, it's just not an option. It's not approved by insurance, cash only. And so that's, I don't know if it's going to happen here anytime soon because our country's going backwards as fast as you can go. But I think it's brilliant. And what I've seen from people that can do it, it's absolute. Because what I did is you're just looking like this, man, shit, let's do it this way. That's what we do. You know, you measure all this stuff and it's just, it's stupid. So yeah, the future is definitely has to be more intelligent and accurate.
Anything else, Sampath, you want to deliver as a message to the audience?
Actually, you talked about 3D printing. I would say that everyone go to the console, CT console, read CT scan yourself. You can align those cuts yourself. Even we don't read CT scan in console. We read those films. Those films are of no use because they are given to you by a technician. Go to console, read your CT scan yourself, and you will get a lot of information.
Yeah. Okay. So allow me to wrap up this. Thank you very much, Sunil, Girish, Amit, Rajesh, Anish, Ashish, and Sampath to be here. Thanks, Ashok, to give us a terrific support. I kept my word. I'm still another 3-4 minutes left for the deadline to reach. But thank you very much, everyone, to be part of this IOA bounce back webinar for designed for IOACON, which is coming up in 2021. We postponed it by a year, and hopefully we will hook onto each other during TraumaCon World. If any of you want to know more about it, we have Trauma Society of India Facebook page. Hit there and you will get to know all the details of TraumaCon World. So thank you very much. Thanks for being part of the team. Thank you, Sampath, for understanding.
Nice.
And we'll be there again. Thanks, Ashish, for waking up.
We have not met before. So
sorry, Sunil.
On the recording.
Yeah. So take care and bye-bye, everyone.
Okay.
Thank you.
Take care, guys.
Stop recording.